Neuroendocrine tumors. Jonathan R. Strasberry, Tamea Altuba 34. Neuroendocrine tumors, NET, originate from the diffuse neuroendocrine system discussed in Chapter 4.1,2. Gastroenteropancreatic NETs, GEPNETs, can originate in the GI tract, GINETs, also known as carcinoid tumors, and pancreas, NETs. GEPNETs are characterized by a propensity to produce hormones and other vasoactive substances. Tumors that secrete hormones resulting in a clinical syndrome are also known as functional tumors, Table 34.1, 318, whereas tumors that are non-secretory or secrete inactive proteins are termed non-functional. GINETs and NETs have many similarities, and in these similar areas they are discussed together. Where there are important differences, they are discussed separately. Historical aspects. Langerhans described the histology of a carcinoid tumor in 1869. Lubbersk in 1888 described ileal carcinoid tumors at autopsy. The term carcinoid, was coined by Oberndorfer to describe a tumor that was less aggressive than an adenocarcinoma. 19 Schulte in 1931 described the carcinoid syndrome in a patient experiencing edema, sweating, flushing, and diarrhea, with a 1 cm ileal carcinoid and a thickened tricuspid valve. Lembeck in 1952 showed that the enterochromaffin, EC, cell, described by Kulczycki in 1897, was the putative carcinoid cell of origin and synthesized and secreted serotonin. 19 The first pancreatic hormone-producing tumor syndrome was described in 1927, 5 years after the discovery of insulin, in a hypoglycemic patient with a metastatic islet cell tumor. Extracts from the tumor had hypoglycemic effects. 20 Many other hormone-producing NETs have since been described or proposed, see Table 34.1. Epidemiology. The annual incidence of clinically significant GEPNETs is rising significantly, Fig 34.1. Data from the Surveillance, Epidemiology, and End Results, SEER, 18 database, 20002012, demonstrated an annual incidence of 3.56 per 100,000 for GEPNETs, and 0.84 per 100,000 for NETs of unknown primary site. 21 The incidence of GI NET on autopsy is even higher at 8.4 per 10,000, demonstrating that many are clinically silent. 22-24 The principal cause of the rising incidence of NETs is not clear, as there are no known environmental risk factors. It is likely that this increase is related to greater use of endoscopic procedures, increased imaging, and improved recognition of NETs by pathologists. 22-24 NETs account for 1% to 10% of tumors arising in the pancreas. 25-27 The overall prevalence of functional NETs is low, reported to be approximately 1 in 100,000. 5 In contrast, the prevalence of NETs in autopsy studies is 0.5% to 1.5%. 28 The annual incidence of NETs is approximately 0.8 per 100,000. 24 The overall incidence of NETs increases with age and peaks in the 6th and 7th decades. Non-functional NETs account for 60% to 80% of all NETs in recent studies. 12,29,30 The incidence of functional NETs varies, with insulinomas and gastrinomas representing the most common subtypes, with annual incidences of 0.5 to 3 in 1 million, see Table 34.1. 1231-34 Origin and histochemical features. GINETs arise from enterochromaffin cells which form part of the diffuse neuroendocrine cell system scattered throughout the GI tract, respiratory tract, and other tissues. 22-35 NETs may originate from the islets of Langerhans, which are also a component of the diffuse neuroendocrine system. 1236-37 Cells of this system share certain cytochemical properties, and were originally proposed to have a common embryonic origin from neural crest cells, although more current studies support both a neural crest and endodermal origin. 35 Ultrastructurally, the neuroendocrine cells often have electron-dense granules that contain multiple regulatory hormones and amines, neuron-specific enolase, synaptophysin, and chromogranin. GINETs and NETs have marked histologic similarities. 38 Well-differentiated tumors consist of relatively homogeneous small round cells with uniform nuclei and cytoplasm, often arrayed in islets or trabeculae, Fig 34.2. Mitotic figures are characteristically infrequent, 2 mitoses/high power field, and necrosis is uncommon. 39 Malignancy can be determined only by metastases or tissue invasion and cannot be predicted by light microscopic or Fig 34.1 Incidence of different subtypes of neuroendocrine tumors, 1970-2005. From Maudlin I.M., Oberg K., Chung D.C., et.al. Gastroenteropancreatic neuroendocrine tumors. Lancet Onco. 2008, 9:6172. 1.4, 1.2, 1.00, 0.80, 0.60, 0.40, 1970, 1975, 1980, 1985, 1990, 1995, 2000, 2005 Incidence, per 100,000. Year lung and bronchus, small intestine, rectum, other non-epithelial skin, stomach, appendix, cecum, pancreas, sigmoid, colon, recto-sigmoid junction. Table 34.1 Syndromes associated with pancreatic neuroendocrine tumor. SAW syndrome incidence /106/year symptoms /signs malignancy, %. Hormone insulinoma 1 to 2. See Table 34.5. 10 Insulin gastrinoma, ZES. 0.5 to 1.5. See Table 34.6. 60 to 90 Gastroenteropoma, Werner-Morrison syndrome, WDHA, pancreatic cholera, 0.05 to 0.2. See Table 34.7. Greater than 60 VIP glucagonoma, 0.01 to 0.1. See Table 34.7. 50 to 80 glucagon grphoma, unknown. Acromegaly greater than 30 GHRFACT homa, uncommon. Ectopic Cushing syndrome, 95% ACTH net secreting PTHRP. Rare symptoms from hypercalcemia, 84% PTHRP. Pancreatic carcinoid tumor, rare, 1% of all carcinoids. Carcinoid syndrome, see Table 34.11, 77% serotonin, tachykinase pnet secreting renin. Rare hypertension, unknown. Renin pnet secreting erythropoietin. Rare polycythemia, unknown. Erythropoietin pnet secreting luteinizing hormone. Rare masculinization, female, loss of libido, male, unknown. Luteinizing hormone pnet secreting cholecystokinin, CC coma. Rare diarrhea, gallstones, peptic ulcer, weight loss, unknown. CCKA. These syndromes may also be caused by a GI net, carcinoid. GHRF, growth hormone releasing factor, PP, pancreatic polypeptide, PTHRP, parathyroid hormone related protein, VIP, vasoactive intestinal polypeptide, WDHA, watery diarrhea, hypokalemia, achlorhydria. 474 Part 4 Topics involving multiple organs. Ultrastructural studies. 40 Controversy surrounds the exact cell of origin for NITs. 36,41 NITs are often called islet cell tumors, but it is uncertain that they originate from the pancreatic islets. 1134-36 These tumors frequently contain ductular structures, and they often produce hormones not normally present in the adult pancreas, such as gastrin and vasoactive intestinal polypeptide, VIP. 42 Finding of ductular structures in many NITs, and the budding off of endocrine cells from ductules during ontogenesis of the pancreas, see Chapter 55, has led to the speculation that these tumors are ductular in origin. 41 GINETs and NITs can produce multiple GI hormones, which can be localized by immunocytochemical methods. 38-39 In many studies, most functional and non-functional GINETs, carcinoid, and NITs have cells containing peptides that were not causing clinical symptoms. 39,42 It is unclear why usually only one syndrome or no clinical syndrome is seen, despite the presence of multiple hormones in the tumor. 40,42 As discussed later, a functional PNET syndrome or the carcinoid syndrome should, therefore, be diagnosed only if the appropriate clinical symptoms are present, and not only based on immunocytochemistry alone. Well-differentiated GINETs, NITs, and respiratory tract NETs appear similar histologically. Thus, predicting the site of the primary NET in a patient with a metastasis is difficult. Recent studies report that NETs from varying sites can differentially express transcription factors, including CDX2, pancreatic and duodenal homeobox factor 1, PDX1, TTF, PAX1, and ISL1. A panel of these factors can be used to localize the source of the primary NET from a metastatic focus point. 43,44 classification tumors are classified by their grade and differentiation, which are vitally important prognostic markers. Grade refers to the proliferative activity of the tumor, measured using both mitotic rate and Ki-67 index. Differentiation refers to the extent to which tumor morphology resembles endocrine cells of origin. Poorly differentiated tumors are often characterized as sheets of pleomorphic cells with regions of necrosis. 45 Poorly differentiated neuroendocrine carcinomas tend to be highly aggressive malignancies with high proliferative activity. Virtually all poorly differentiated tumors are high-grade. In the 2010 WHO classification of GINETs, low-grade tumors were defined as having 0 to 1 mitoses per 10 high-powered fields, HPF, and Ki-67 index of 0% to 3%, intermediate-grade tumors having a mitotic rate of 2 to 20 per 10 HPF or Ki-67 3% to 20%, and high-grade tumors as having mitotic rate greater than 20 per 10 HPF or Ki-67 index 20%. Well-differentiated NETs were subclassified into low and intermediate-grade categories, whereas poorly differentiated carcinomas were considered equivalent to high-grade. Table 34.2a. Point 46. One pitfall with this classification was that it negated the possibility of a well-differentiated high-grade tumor, an entity that is ABCD. Fig 34.2 gross and histologic sections of a GI net, carcinoid, and a PNET. A. Gross section of a carcinoid in the small intestine. The size is typical for primary small intestinal carcinoids, and the tumor is subepithelial in location. B. Histopathology of a small intestinal carcinoid with its characteristic insular growth pattern. HNE, 80. C. Hemorrhagic and cystic 2 cm PNET, gastronoma, in the tail of the pancreas, arrow. D. Histopathology of gastronoma, similar to that of other NETs. This highly vascular tumor is composed of tubules of bland endocrine cells. Table 34.2a WHO classification for GI NETs, 2010 differentiation grade WHO grading WHO nomenclature well differentiated low, G1, 2 mitoses/10 HPF and 3% Ki-67 index NET grade 1 intermediate, G2, 220 mitoses/10 HPF or 3% 20% Ki-67 index net grade 2 poorly differentiated high greater than 20 mitoses/10 HPF or 20% Ki-67 index neuroendocrine carcinoma, grade 3, large cell or small cell type, HPF, high-powered fields, NET, neuroendocrine tumors, WHO, World Health Organization. Chapter 34 Neuroendocrine Tumors 475-34 increasingly recognized, particularly in pancreatic NETs. The 2017 WHO classification for NETs has, therefore, expanded the well-differentiated category to include low, intermediate, and high-grade tumors. Table 34.2b, point 47. It is important to note that current classifications use the term neuroendocrine tumor to describe well-differentiated NETs, and neuroendocrine carcinoma or NEC to denote poorly differentiated morphology. Formal TNM staging classifications have been introduced for GEP-NETs in the past decade by the American Joint Committee on Cancer, AJCC, and the European Neuroendocrine Tumor Society, ENETS. Validations of both staging systems have been performed on population and institutional databases. Molecular pathogenesis. Until recently, the molecular pathogenesis of NETs was largely unknown. 4851 In contrast to many non-endocrine GI tumors, e.g., colonic or pancreatic adenocarcinoma, mutations in common oncogenes, e.g., RAS, FOS, MYC, SRC, JUN, and tumor suppressor genes, e.g., P53, RB, are rare in well-differentiated NETs. 12,28 Recent genomic analyses of NETs have provided significant insight into the genetic landscape of these tumors. In a landmark whole exome study of 68 sporadic NETs, somatic mutations of MEN1 were observed in 44% of cases, whereas mutations in DAXX, death domain-associated protein, or ATRX, thalassemia/mental retardation syndrome SLINCT, were seen in 43%. 50 All three genes are associated with chromatin remodeling. Also, 14% of samples had mutations in mammalian target of rapamycin, mTOR, pathway genes including PTEN, TSC2, and PIK3CA. Similar findings were reported in a whole genome sequencing study of 102 primary NITs. 4 dysregulated signaling pathways were described: 1. DNA damage repair, 2. Chromatin remodeling, 3. Telomere maintenance, 4. mTOR activation. A higher than expected proportion of germline mutations was found in clinically sporadic NITs, with mutations of MUTI, CHEK2, and BRCA2 occurring in 11% of patients. 52 The precise sequence of gene mutations driving the development and progression of NITs is currently unknown. Loss of DAXX/ATRX expression is associated with activation of the alternative lengthening of telomeres, ALT, pathway and chromosomal instability, CIN. Additional mutations can accumulate over time and are associated with clinical progression. The genetic landscape of poorly differentiated NICs is markedly distinct from well-differentiated NITs. Mutations of CRAS and loss of RB have been reported in 55% and 49% of patients with NICs. Overall, frequency of mutations is substantially higher in NEC versus NET. 53 The molecular landscape of GINETs is much less well understood than NITs. Loss of chromosome 18 has been reported in over 60% of small intestinal, SI, NETs, but the biological significance of this alteration is uncertain. 54 Overall, a low mutational rate, 0.1 somatic single nucleotide variants/105 nucleotides, has been observed in SI NETs, with mutations or deletions of the cyclin-dependent kinase inhibitor gene CDKN1B observed in 8% of patients. 55 Epigenetic changes appear to play a fundamental role in progression of SI NETs. Global DNA hypomethylation is a characteristic feature of SI NETs, whereas tumors with high methylation index tend to be clinically aggressive. Progressive changes in DNA methylation have been detected between primary tumors and their metastases. 56,57 The mTOR pathway appears to be significantly dysregulated in many GEP-NETs, even in the absence of identifiable mutations in pathway components. mTOR is a serine/threonine kinase that modulates cell survival and proliferation, angiogenesis, and metabolism. Overexpression of mTOR and/or its downstream targets is frequently detected in NETs, and is associated with poorer prognosis. 58 Expression of tuberous sclerosis 2, TSC2, and phosphatase and tensin homolog, PTEN, inhibitors of the mTOR pathway, is decreased in the majority of NETs. Furthermore, decreased expression of TSC2 and PTEN correlate with reduced survival. 59 NETs are highly vascular tumors, and angiogenesis has been identified as a key event in NET progression. Overexpression of proangiogenic factors, including fibroblast growth factor, FGF, platelet-derived growth factor, PDGF, and vascular endothelial growth factor, VEGF, as well as of their receptors, has been reported. 60 Multiple endocrine neoplasia and other inherited syndromes. MEN1 Wermer syndrome, is characterized principally by hyperparathyroidism, multifocal pancreaticoduodenal NETs, and pituitary adenomas. The genetic defect in MEN1 is located on chromosome 11q13 and is caused by germline mutations in a 10EXON gene encoding for a 610 amino acid protein, menin. Table 34.3, 61,62 Menin is a nuclear protein that interacts with many proteins, including the AP1 transcription factor, nuclear factor, NF, kappa beta, RPA2, a DNA processing factor, FAN-CD2, a DNA repair factor, and various cytoskeleton-associated proteins and histone-modifying enzymes. 61-63 Menin has important roles in transcriptional Regulation, genomic stability, cell division, and cell cycle control. 61,63,64 The exact mechanism of carcinogenesis is unclear. 65,66 Development of endocrine tumors in patients with MEN1 conforms to Knudsen S11,61 2HIT model theory of neoplasm, with an inherited, germline, mutation in one chromosome unmasked by a somatic deletion or mutation of the other normal chromosome, thereby removing the tumor suppressor effect of the normal gene product. 61,62 Numerous, greater than 1,300, different mutations have been described in MEN1, with over 75% of them being inactivating. 62 Hyperparathyroidism is the most common clinical abnormality in patients with MEN1, Table 34.4, 61,67-69 Characteristically, hyperparathyroidism is the initial manifestation of MEN1, usually presenting in the third decade of life, followed by the development of a PNET in the fourth to fifth decades. 61 Pituitary adenomas occur in roughly 20% of patients. Non-functional NETs are nearly universal in patients with MEN1 and pathology studies 12,61,68,70 have demonstrated that in almost every patient with MEN1, the pancreas demonstrates diffuse microadenomatosis, with or without larger tumors. Among functional tumors, gastrinomas are most common, typically occurring in the duodenum. It is important to recognize when a patient with a PNET has MEN1, because patients with and without MENI differ in their clinical presentations, the need for family screening, in the likelihood of surgical cure, and in the clinical and diagnostic approach to the tumor. 61,71-73 Table 34.2b WHO classification for pancreatic NETs, 2017 differentiation grade WHO grading WHO nomenclature well differentiated low, G1, 2 mitoses/10 HPF and 3% Ki67 index net grade 1 intermediate, G2, 220 mitoses/10 HPF or 3% 20% Ki67 index net grade 2 high, G3, greater than 20 mitoses/10 HPF or 20% Ki67 index net grade 3 poorly differentiated high greater than 20 mitoses/10 HPF or 20% Ki67 index neuroendocrine carcinoma, grade 3, large cell or small cell type, HPF, high-powered fields, NET, neuroendocrine tumors. 476 Part 4 Topics involving multiple organs. Von Hippel-Lindau disease. Von Hippel-Lindau disease, VHL, is caused by a defect on chromosome 3p25 encoding for a 232 amino acid protein, PVHL, that forms a complex with a number of proteins that regulate ubiquitin-dependent proteolysis of large cell proteins and target the hypoxia-inducible factor, HIF. Alpha.74 VHL mutations result in altered transcriptional regulation, resulting in pathologic changes in angiogenic, growth, and mitogenic factors. Pancreatic lesions, primarily cysts, occur in 60% of VHL patients. NETs are present in 10% to 17% of patients with VHL. The NETs are usually, 98%, asymptomatic and non-functional. The mean age at diagnosis of PNET in VHL is 29 to 38 years. Most patients have a single PNET that may be malignant. 75 Liver metastases occur in 9% to 37% of VHL patients with NETs. Neurofibromatosis 1NF1 is caused by a defect on chromosome 17q11.2 encoding for a 2845 amino acid protein, neurofibromin, which functions as a RAS signaling cascade inhibitor. See Table 34.3, 61,76 From 0% to 10% of NF1 patients develop a genet, carcinoid, usually in the periampullary region of the duodenum. 61,77,78 These tumors frequently contain round calcium concretions, psammoma bodies, typical of somatostatinomas, although the somatostatinoma syndrome is rarely present. Metastases to liver and or lymph nodes occur in 30%. 61,78 Tuberous sclerosis. Tuberous sclerosis is caused by mutations in either the 1164 amino acid protein, Hamardin, TSC1, or the 1807 amino acid protein, tuberin, TSC2, see Table 34.3.61. These two proteins regulate the PI3K signaling cascade and the small guanosine triphosphatase, GTP, binding protein RHEB, RIS homolog enriched in brain, which play important roles in the regulation of protein translation and synthesis, growth, and proliferation, as well as maintenance of cellular energy levels. NITs are present in 4% of patients with TSC2. Functional tumors. Insulinomas. Insulinomas are insulin-secreting NITs that primarily originate in the pancreas and cause symptoms as a result of hypoglycemia, Table 34.5. Pathophysiology and pathology. Insulinomas are almost always located in the pancreas. 12, 28, 31, 39, 79, 81. Insulinomas are evenly distributed in the pancreas and are usually fairly small. 12, 28, 31, 39, 79, 82. In one series, 39% were smaller than 1 cm and only 8% were larger than 5 cm. 82 insulinomas occur as multiple tumors in only 2% to 13% of patients. 28,82 in which case MEN1 should be suspected. 61 insulinomas are usually well encapsulated, firmer than normal pancreas, and highly vascular. Only 5% to 16% of insulinomas are malignant. 83 malignant insulinomas, generally large, average size, 6 cm in one series. 84, metastasize most often to the liver and/or regional lymph nodes. Insulin is synthesized as preproinsulin by beta cells of the pancreatic islets in the rough endoplasmic reticulum. Proinsulin is liberated from preproinsulin and transferred to the Golgi apparatus. 32 proinsulin, consisting of a 21 amino acid alpha chain and a 30 amino acid beta chain joined together by a 33 amino acid connecting peptide, CPE peptide, is stored in beta cell secretory granules. Within these granules, a protease excises the CPE peptide, and the CPE peptide and the double-stranded insulin molecule are secreted in equimolar amounts. 32 Some proinsulin is also detected in normal subjects but represents less than 25% of total immunoreactive plasma insulin, whereas in almost all, 90%, patients with insulinomas, there are elevated proportions of proinsulin relative to total insulin. 85 Table 34.3 Inherited GI neuroendocrine tumor syndrome prevalence /105 Genetic defect, S altered protein, S, net frequency types of PNET multiple endocrine neoplasia type I, MENI, 1 to 10 11Q13, menin, a 6-10 amino acid nuclear protein that interacts with pathways involved in cell growth, cell cycle regulation, genomic stability, and apoptosis. NITs 80% 100%, microscopic, 20% 80%, clinical, carcinoids, gastric, 15% 35%, pulmonary, 0% 8%, thymic, 0% 8%. NF NITs, 80% 100% microscopic, 0% 20% large, functional NITs, gastrinoma, 54%. Insulinoma, 18%. Glucagonoma, 3%. Vipoma, 3%. Grphoma, 1%. S-soma, 1%. Von Hippel-Lindau disease, VHL, 2 to 3,3P25, PVHL, a 232 amino acid protein that interacts with transcriptional factors that downregulate HIF and VEGF. 10% 17%, NITs, NF NITs, 98% functional, 2% neurofibromatosis. 1, NF1, von Recklinghausen disease, 20 to 25 17Q11.2, neurofibromin, a 2484 amino acid protein that has RASGT PASE activity, binds microtubules, regulates mTOR growth, and induces cell cytoskeleton changes. 0% 10%, duodenal carcinoids, rare NITs. S-somas tuberous sclerosis. Bourneville disease, 10-9Q34, TSC1, and 16P13, TSC2 Hamarden, 1164 amino acid protein and tuberin, 1807 amino acid protein, which interact with the PI3K signaling cascade that regulates mTOR growth, GT-PASE activity affecting cell growth, energy regulation, response to hypoxia, and nutrients uncommon NF PETs functional NITs GRF, growth hormone releasing factor, GTP, guanosine triphosphate, HIF, hypoxia inducible factor, mTOR, mammalian target of rapamycin, PNET, pancreatic neuroendocrine tumor, NF, non-functional, SS, somatostatin, VEGF, vascular endothelial growth factor. Chapter 34 Neuroendocrine Tumors 477 34 Clinical features. Insulinomas usually occur in patients between 20 and 75 years of age. 60% are women. 10, 12, 28, 31, 39, 79, 81 Hypoglycemic symptoms are characteristically associated with fasting. 10, 28, 79, 81 Symptoms may also occur during exercise. Hypoglycemia with fasting or exercise differs temporally from hypoglycemia that occurs after meals. Postprandial hypoglycemia, which can be caused by many unrelated conditions. 8691 The distinction between fasting hypoglycemia and postprandial, reactive, hypoglycemia can usually be made by a careful history. Other less common causes of fasting hypoglycemia with hyperinsulinism from islet cell disease, besides insulinoma, include insulinomatosis, islet hyperplasia 92 and nesidioblastosis. 93 In insulinomatosis, many macro and microadenomas. Table 34.4 Clinical features of patients with multiple endocrine neoplasia. Type I features. Frequency, %. Range hyperparathyroidism 97-78 to 100 Pancreatic endocrine tumor, any, including PPOMA or non-functional 80 to 100 Gastronoma 54-20 to 61 Insulinoma 18-7 to 31 Glucagonoma 3-1 to 6 VIPoma 1-1 to 12 Somatostatinoma 0 to 1 GRFoma 1 Pituitary tumor any 60-15 to 100 Prolactin secreting 15 to 46 Growth hormone secreting 6 to 20 ACTH secreting, Cushing syndrome, 16 Adrenal cortical tumors 27 to 36 Symptoms 2 Carcinoid tumor gastric, E-celoma, 7 to 35, symptoms 5 Lung 0 to 8 Thymus 0 to 8. Skin findings angiofibroma 88 Cholagionoma 72 Cafeola macules 38 Lipomas 34 CNS tumor meningioma 0 to 8 Ependymomas and schwannomas Leiomyoma, leiomyosarcoma 1 to 7 Thyroid adenoma 50 to 30 asymptomatic in 1%. CNS, Central Nervous System, ECL, enterochromaffin-like, GRF, growth hormone releasing factor, PP, pancreatic polypeptide, VIP, vasoactive intestinal polypeptide. Data modified from Jensen RTGJ. Gastronoma. In, GoVLW Day, Gardner JD, ETL, EDS. The Pancreas, Biology, Pathobiology, and Disease. 2nd ed. New York, Raven Press, 1993, pp 931-78, Jensen RT, Berna MJ, Bingham DB, ETAL Inherited pancreatic endocrine tumor syndromes, advances in molecular pathogenesis, diagnosis, management, and controversies. Cancer 2008, 113:180743, Thucker RV Multiple endocrine neoplasia type 1. Endocrinal Metabclin North AM 2000, 29:54167, Gibril F., Schumann M., Pace A., ETAL Multiple endocrine neoplasia type 1 and Zollinger-Ellison syndrome, a prospective study of 107 cases in comparison with 1009 cases from the literature. Medicine, Baltimore, 2004, 83:4383, Gibril F., Jensen RT Advances in Evaluation and Management of Gastronoma in Patients with Zollinger-Ellison Syndrome. Kerr Gastroenterol Rep 2005, 7:11421. Table 34.5 Symptoms, Signs, and Laboratory Abnormalities in Patients with Insulinoma Frequency, %. Anytime during the clinical course. A neuropsychiatric symptoms, loss of consciousness, confusion, dizziness, diplopia, 92 confusion or abnormal behavior 80 obesity 52 amnesia or coma 47 seizures, grand mal, 12 cardiovascular symptoms, palpitations, tachycardia. 17 GI symptoms, hunger, vomiting, abdominal pain. 9 During the first attack, neuroglycopenic symptoms, visual disturbances, diplopia, blurred vision. 59 Confusion. 51 Altered consciousness. 38 Weakness. 32 Transient motor defects, hemiplegia. 29 Dizziness. 28 Fatigue. 27 Inappropriate behavior. 27 Speech difficulty. 24 Headache. 23 Seizure. 23 Syncope. 21 Difficulty concentrating or thinking. 19 Paresthesia. 17 Memory loss. 15 Lethargy. 12 Amnesia. 8 Stupor. 12 Ataxia. 4 Disorientation. 4 Mental change. 4 Adrenergic symptoms, sweating. 43 Tremulousness. 23 Hunger, nausea. 12 Palpitations. 10 A data from refs service. FJ, Dale AJ, Elvbach LR, ETAL. Insulinoma, clinical and diagnostic features of 60 consecutive cases. Mayo Clin PROC 1976, 51:4-1729, Stefanini P., Carboni M., Patrici N., ETAL. Beta islet cell tumors of the pancreas, results of a study on 1067 cases. Surgery 1974, 75:597-609. B. Data modified from Hirschberg B., Cochrane C., Scarulis M.C., et.al. Malignant insulinoma, spectrum of unusual clinical features. Cancer 2005, 104:264-72. 478 Part 4 Topics involving multiple organs expressing insulin are present with multiple small proliferative insulin-expressing monohormonal endocrine cell clusters. Most symptoms of insulinomas 12,28, 31, 39, 82 are caused by neuroglycopenia, because glucose is the main source of energy for the brain. Symptoms of hypoglycemia can also be caused by catecholamine release, adrenergic symptoms. Patients frequently learn to avoid symptoms by eating frequently, and obesity may result. 83 Neuroglycopenic symptoms can occur for several years before the diagnosis of insulinoma. 85 Diagnosis keys to establishing the diagnosis of insulinoma are to suspect from the clinical history that the patient's symptoms could be caused by hypoglycemia and to establish a relationship of their symptoms to fasting. 10, 12, 28, 31, 39, 79, 81, 90 Whipple triad, namely hypoglycemic symptoms, hypoglycemia, blood sugar 50 mg/dl, and relief of symptoms following glucose ingestion, is not specific for insulinoma. 83 Following an overnight fast, fewer than 40% of patients with insulinoma have a blood glucose level below 50 mg/dl. However, if a fasting blood glucose determination is combined with a concomitant fasting plasma insulin level, this insulin level will be inappropriately elevated in 65% of patients with insulinoma. 12 In patients lacking clear radiographic evidence of disease, an extended fast can be done, with blood glucose, plasma insulin, and CPE peptide levels measured at 3 to 6 HOUR intervals. 10, 12, 28, 31, 39, 79, 81, 90 Traditionally, a 7 to HOUR fast is planned, but if at any point during the fast the patient becomes symptomatic, plasma insulin and glucose values should be determined before 4 glucose is given and the test stopped. 75 to 80% of patients with an insulinoma will have symptoms and a blood sugar below 40 mg/dl within 24 hours of starting the fast, and almost 100% within 72 hours. 10, 12, 28, 31, 39, 90 In healthy, non-obese fasted subjects, plasma insulin concentrations decrease to less than 6 μu/ml when blood glucose levels decrease to less than 40 mg/dl, and the ratio of plasma insulin, in μu/ml, to glucose, in mg/dl, remains less than 0.3. Thus, a plasma insulin to blood glucose ratio over 0.3 is considered positive for insulinoma. In one study 85 the most sensitive and specific criteria for diagnosing insulinoma during a 7 to HOUR fast was the combination of a fasting glucose level below 45 mg/dl plus an elevated proinsulin level. Multiple imaging studies can help localize insulinomas. These include multiphasic CT scans and EUS. Somatostatin receptor imaging, typically with the somatostatin receptor 2 analog GA68 dotatate PET scan, is not routinely necessary unless metastases are suspected, or unless a suspected insulinoma cannot be detected using other methods. Invasive imaging studies using hepatic venous sampling after arterial calcium stimulation are rarely necessary to localize an occult insulinoma. Treatment of insulinoma consists of controlling symptoms of hypoglycemia, followed by tumor localization and resection. Tumor localization of all NITs is discussed later, as is chemotherapy or other therapies directed at the tumor itself for the 5% to 13% of patients with metastatic insulinoma. 84,9497 Medical therapy. Hypoglycemia is controlled in most insulinoma patients by a combination of dietary and pharmacologic therapy. 10,12,28 31 39, 83, 97 Snack intake should not be restricted to rapidly absorbed carbohydrates, because their ingestion may occasionally stimulate insulin secretion from the tumor. More slowly absorbed forms of carbohydrates, starches, bread, potatoes, rice, are preferable. During a hypoglycemic episode, however, rapidly absorbable carbohydrates such as fruit juices with glucose or sucrose are preferable. Occasionally, patients with severe hypoglycemia may require the use of a continuous 4 infusion of glucose together with an increase in dietary carbohydrates. 12 Diazoxide, a non-diuretic thiazide analog, has potent hyperglycemic effects. 10, 12, 96, 98, 99 It directly inhibits insulin release from beta cells through stimulation of adrenergic receptors and also has an extrapancreatic hyperglycemic effect that enhances glycogenolysis. 83 The GI side effects can be reduced by taking the diazoxide with a meal. Diazoxide should be initiated at an oral dose of 3 to 8 mg/kg/day, divided into 2 or 3 doses per day. If not effective, diazoxide can be increased to a maximum daily dose of 15 mg/kg. Adverse effects are dose-related and may limit the ability to reach maximal doses. They include sodium retention/edema, GI symptoms such as nausea, and hirsutism. Addition of a thiazide diuretic can correct the edema as well as augment the hyperglycemic effect of diazoxide. Somatostatin analogues, SSAs, can control symptoms of hypoglycemia in 40% to 60% of patients with insulinoma. SSAs are thought to act primarily by interacting with somatostatin receptors on the tumor, especially subtypes 2 and 5.100. The symptomatic response rate of insulinomas to octreotide is lower than that of other functional NITs, because insulinomas generally have low levels of somatostatin receptors. 101 Because SSAs also decrease glucagon and growth hormone secretion, occasionally their administration may worsen the hypoglycemia. 94 Therefore closely monitored trials of short-acting octreotide are generally recommended prior to administration of long-acting depot formulations of octreotide or lanreotide. Everolimus, an mTOR inhibitor which causes hyperglycemia as a side effect, has been shown to be effective in controlling hypoglycemia in patients with metastatic insulinomas refractory to other therapies. Other cytotoxic systemic and liver-directed therapies, discussed later, can also control hypoglycemia in patients with metastatic insulinomas. 10,102 Surgical therapy. Because the large majority of insulinomas are localized 103-105, surgical resection is curative in 70% to 97% of patients. 12, 98, 106, 107 Because insulinomas are almost invariably intrapancreatic and usually benign, insulinomas detected on imaging preoperatively are increasingly being resected successfully using a laparoscopic approach. 98, 108, 109 Gastrinomas ZES is caused by ectopic secretion of gastrin by a NET, gastrinoma, which causes excessive gastric acid secretion, characteristically causing peptic disease, often severe, and/or GERD. 110 This disease was first described in 1955 by Sleisenger and Ellison in 2 patients with extreme acid hypersecretion and intractable PUD caused by a non-beta cell tumor of the pancreas. Pathophysiology and pathology. Almost all the symptoms of ZES are caused by gastric acid hypersecretion, Table 34.6. PUD, GERD, and diarrhea disappear when gastric acid hypersecretion is controlled. 10,16,111,112 Parietal cell hyperplasia driven by hypergastrinemia increases the stomach's maximal acid secretory capacity, and the chronic hypergastrinemia also increases basal acid secretion. Characteristic findings in ZES. 112 The high serum gastrin levels are trophic for the gastric mucosa, resulting in large gastric folds. Fig 34.3, with not only parietal cell but also gastric enterochromaffin-like, ECL. Cell hyperplasia. 11,112115 More than 99% of patients with ZES show some degree of ECL hyperplasia 114116, but the changes are generally much more advanced in the patients with Chapter 34 neuroendocrine tumors 479-34 men 1/ZES. Furthermore, type 2 gastric carcinoids, discussed later, are rarely seen in sporadic, non-MEN1, ZES cases, whereas 23% of patients with MEN1/ZES develop type 2 gastric carcinoid tumor, S. 116 Increased gastric acid secretion results in diarrhea from direct acid damage in the small intestine. Furthermore, the low pH inactivates pancreatic lipase and can precipitate bile acids. 16 More than half of gastrinomas are found in the duodenum, with 56% of these occurring in the first portion and approximately 32%, 6%, and 4% in the second, third, and fourth portions of the duodenum, respectively. 71, 73, 81, 111, 117, 118 Presently, 60% to 90% of gastrinomas are found in the gastrinoma triangle, an area formed by the junction of the cystic duct and bile duct posteriorly, the junction of the second and third parts of the duodenum inferiorly, and the junction of the pancreatic neck and body medially. 119 Gastrinomas rarely originate in a non-duodenal/non-pancreatic abdominal location. 120 Lymph node primary gastrinomas are reported in up to 11% of sporadic cases of ZES. 81, 111, 121, 122 Some patients with sporadic ZES remained normogastronemic and apparently cured after a follow-up to 20 years following resection of only lymph node S containing gastrinoma. Based on lymph node or hepatic metastases, gastrinomas are malignant in 60% to 90% of patients. 40, 123 Bone metastases also occur in almost one-third of patients with tumors metastatic to the liver, most often to the pelvis, scapula, and ribs. 124 Gastrinomas demonstrate two general growth patterns: aggressive disease, in 25%, and non-aggressive disease, in 75%. 27, 110, 125, 126 In one study, predictors of hepatic metastases were a pancreatic, as opposed to a non-pancreatic, gastrinoma and a primary tumor size larger than 3 cm. Even among patients with gastrinomas that have metastasized to the liver, the tumor growth rate is highly variable. 127 Over 90% of duodenal gastrinomas are small, 1 cm, whereas only 8% of pancreatic gastrinomas are small. The difference in biological behavior and prognosis of duodenal and pancreatic gastrinomas has been used to support the hypothesis that they have different origins. 128 Clinical features. The clinical features of ZES are summarized in Table 3.4.6.129. Abdominal pain primarily caused by PUD remains the most frequent early symptom. Ulcer pain is clinically indistinguishable from that seen in patients with other forms of PUD. 40, 111, 129 The diagnosis may be suggested when ulcer-like symptoms become persistent, refractory to medication, or associated with complications. See Fig 34.3. 10, 130 Most patients with ZES have a typical duodenal ulcer at diagnosis. This is an important difference from older studies, where over 90% of patients presented with PUD, often with multiple ulcers or in atypical locations. 112, 123, 131 In older studies, up to 100% of patients presented with, or developed, a complication of peptic disease, bleeding, perforation, obstruction, penetration, esophageal stricture. Presently, fewer than 30% of patients develop these complications, even though most have a confirmed history of PUD. 129 Diarrhea occurs with abdominal pain in 28% to 56% of cases and may be the only initial symptom in 10% of patients. 10,129 Nearly 1 in 3 patients present with GERD as the initial manifestation, and approximately half of patients have GERD symptoms and/or esophageal pathology at initial evaluation. 129,132 1 in 4 patients with ZES has MEN1, but the clinical presentation is similar to that of those with sporadic ZES. 61, 68, 73, 133 Clues that should suggest the possibility of MEN1/ZES as opposed to sporadic ZES include 1. A history of nephrolithiasis and/or renal colic, 47% versus 4%, 2. Presentation at a younger age, mean, 34 versus 43 years, and 3. Personal or family history of certain endocrinopathies, see Table 34.4. In a review of patients with MEN1/ZES, 68 close to 90% had hyperparathyroidism, 31% to 60% pituitary disease, 6% to 30% various other NETs, typically lung, and 6% to 16% had other functional NETs. 61, 68 Diagnosis. Despite the widespread availability of serum gastrin assays, diagnosis of ZES continues to be delayed by 4 to 6 years after onset of symptoms. 68, 129, 134 This delay occurs for many reasons. Because ZES is so rare, see Table 34.1, it is often not considered. Second, ZES is usually indistinguishable from other patients with PUD and GERD. 40, 112, 133 Third, recent widespread use of PPIs can both complicate and delay the diagnosis. 130, 134, 137 PPI use has decreased referrals of patients with possible ZES. Table 34.6 Clinical and laboratory features in patients with ZES. NIH range in literature. Clinical features: average age of onset, years, 41 to 53. Average duration of symptoms, years, 5.2 3.2 to 8.7. Male gender, percent, 56 44 to 70. Abdominal pain, percent, 75 26 to 98. Diarrhea, percent, 73 17 to 73. History of confirmed PUD, percent, 71 71 to 93. Heartburn, percent, 44 0 to 56. Nausea, percent, 38 to 37. Vomiting, percent, 25 26 to 51. Bleeding, percent, 24 8 to 75. MENI, percent, 22 10 to 48. Esophageal stricture, percent, 4 4 to 6. GI perforation, percent, 5 5 to 18. Laboratory features, percent, fasting hypergastrinemia, percent, 99 96 to 100. Positive secretin test, greater than 120 pg/ml increase, percent, 94 94. BAO greater than 15 milliequivalent/HR, no prior gastric surgery, or greater than 5 milliequivalent/HR, prior gastric surgery, percent, 93 43 to 100. BAO, basal acid output, MENI, multiple endocrine neoplasia type I, NIH, National Institutes of Health. Data from Gibril F., Schumann M., Pace A., ETAL. Multiple endocrine neoplasia type 1 and Zollinger-Ellison syndrome, a prospective study of 107 cases in comparison with 1,009 cases from the literature. Medicine, Baltimore, 2004, 83:4383, Osfo N., ITOT, Jensen RT. Gastric acid hypersecretory states, recent insights and advances. Kerr Gastroenterol Rep 2009, 11:43441, Berna M.J., Hoffman K.M., Serrano J., ETAL. Serum gastrin in Zollinger-Ellison syndrome, a prospective study of fasting serum gastrin in 309 patients from the National Institutes of Health in comparison with 2,229 cases from the literature. Medicine, Baltimore, 2006, 85:295-340, Berna M.J., Hoffman K.M., Long S.H., ETAL. Serum gastrin in Zollinger-Ellison syndrome, 2. Prospective study of gastrin-provocative testing in 293 patients from the National Institutes of Health in comparison with 537 cases from the literature. Evaluation of diagnostic criteria, proposal of new criteria, and correlations with clinical and tumoral features. Medicine, Baltimore, 2006, 85:34164, Gibril F. Jensen RT Advances in Evaluation and Management of Gastrinoma in Patients with Zollinger-Ellison Syndrome. Kerr Gastroenteral Rep 2005, 7:11421, Rogers A., Wang L.M., Karavitaki N., ETAL Neurofibromatosis Type 1 and Pancreatic Islet Cell Tumors, an association which should be recognized. QJM 2015, 108:5736. 480 Part 4 Topics involving multiple organs has decreased the number of cases of ZES diagnosed, and at the same time has been associated with an increase in patients with a false diagnosis of ZES. 137 A false diagnosis may occur because chronic treatment with PPIs causes hypergastrinemia in 80% to 100% of patients with PUD or GERD, and the serum gastrin level frequently reaches 5 times normal, a level seen in 60% of ZES patients. 130-134-136 In the past, when H2RAS were in wider use, a diagnosis of ZES was frequently suggested when the conventional doses of H2RAS failed to control acid hypersecretion and ulcer disease. 7 Presently, conventional doses of potent PPIs may mask the diagnosis of ZES because they control symptoms in most patients, and treatment failures uncommonly occur with PPIs. 10,129,134,138 Another factor complicating and sometimes delaying the diagnosis of ZES is the reliability of current plasma gastrin assays. 134,139,141 STUDY139 Examining 12 different commercially available plasma gastrin kits, 7 radioimmunoassays and 5 ELISA assays, reported that 7 assays inaccurately measured plasma gastrin concentrations, with both overestimations and underestimations. Thus, a reliable gastrin assay must be used. 134,139 There are a number of clinical and laboratory features that should suggest the diagnosis of ZES in a patient with acid peptic disease or diarrhea. See Fig 34.3 and Table 34.6. First, diarrhea occurs in 73% of ZES patients, but is infrequent in patients with routine PUD or GERD. Diarrhea alone can be the presenting symptom in up to 27% of patients with ZES. 40,112,129 Second, because MEN1 symptoms such as those of PUD, severe GERD, or chronic diarrhea. Signs such as prominent gastric folds on endoscopy, see left upper panel, or an imaging study. Suspect ZES, exclude retained Antrim syndrome by history. 1900 600 300 0 Basal gastric acid output, milli equivalent/HR, serum gastrin concentration, pg/ml, cumulative percent time, min/post injection, no gastric surgery, previous gastric surgery 0 5 10 15 20 secretin, 2 cu/kg, measure fasting serum gastrin, FSG, not elevated, 2% ZES PTS, if strong clinical suspicion, secretin test and BAO elevated, 98% ZES PTS, ZES unlikely normal ZES repeat FSG off drug, H2RA48. HRS, PPI 1 week, measure fasting gastric pH ZES possible ZES likely present ZES possible pH less than or equal to 2 pH 2 ZES unlikely 1% ZES unlikely 1% FSG elevated, 1-9.9 fold, do secretin test measure BAO FSG 10-fold increased FSG normal secretin test, greater than or equal to 120 pg/ml increase in fasting gastrin level BAO greater than or equal to 15 milli equivalent/HR. No previous gastric surgery, greater than or equal to 5 milli equivalent/HR, previous gastric surgery, 120 110 190 80 70 60 50 40 30 20 10 0 110 190 80 70 60 50 40 30 20 10 0 Fasting serum gastrin N equals 205 N equals 30, fold normal, 0110 100 1000 greater than 1190 80 70 60 50 40 30 20 10 0 normal FSG NIH, N equals 309, literature, N equals 2229, Fig 34.3 algorithm for the diagnosis of ZES. Right upper, typical ZES patient with a positive secretin test result, i.e., greater than or equal to 120 pg/ml increase in fasting gastrin level. Right lower, marked elevations in mean basal acid output, BAO, with or without previous gastric acid reducing surgery. The dotted horizontal lines show the proposed criterion of 15 milliequivalent/HR or 5 milliequivalent/HR proposed to distinguish patients with ZE from those without ZES. Left upper, prominent gastric folds found on endoscopy in a ZES patient, compared with a normal subject. Left lower, fasting serum gastrin levels in ZES expressed as a multiple of the upper limit of normal on the horizontal axis. Very few patients had normal values. 60% had less than 10-fold serum gastrin increases 0.40, 73, 130, 142, 150 cu, clinical units. Chapter 34 Neuroendocrine Tumors 481 34 causes 20% to 25% of ZES cases, see Table 34.4. 61,68 Any patient with acid peptic disease and a personal history, family history, or laboratory evidence of a MEN1 compatible endocrinopathy should be suspected of having MEN1/ZES. 0.68, 134 Third, peptic ulcers are HP negative in 50% to 90% of ZES patients, considerably higher than in other PU populations, and thus an HP negative. NSAID negative ulcer should raise suspicion of ZES. 10, 141 Prominent gastric folds on EGD of gastric imaging studies should suggest the diagnosis, see Fig 34.3 and Table 34.6. 129 The endoscopic finding of enlarged gastric folds contrasts with the loss of gastric folds in many patients with gastric hypochlorhydric disorders that result in fasting hypergastrinemia, e.g., chronic atrophic gastritis. See Chapter 52. The diagnosis of ZES requires demonstration of inappropriate gastric acid secretion in the presence of hypergastrinemia, see Fig 34.3, 0.10, 40, 118, 131, 134, 136 Fasting hypergastrinemia occurs in 97% to 99% of patients with ZES. 142 Hence, if the fasting serum gastrin level is normal, especially in repeated determinations, a diagnosis of ZES is very unlikely. Therefore the fasting serum gastrin should be the first study performed when ZES is suspected. 10, 98, 134, 136, 139, 140 Because PPIs can elevate fasting serum gastrin levels, overlapping with plasma gastrin levels in the majority of ZES patients, it can be difficult to diagnose ZES when the patient is taking a PPI. 12, 73, 134, 137, 143, 144 If the fasting gastrin level is elevated while taking a PPI, the general approach is to recommend that the measurement be repeated after stopping the PPI for at least a week, see Fig 34.3, 12, 134, 136, 143, 144 However, if the patient has ZES, abruptly stopping a PPI can lead to rapid development of peptic complications. For this reason, one study suggested PPIs not be stopped and that the diagnosis of ZES be pursued by finding other signs of gastrinoma, e.g., a PNET on imaging, or by trying to taper the PPI dose in some fashion. 145 In rare circumstances, referral to a special center with experience in PPI drug withdrawal and its potential hazards is warranted. 98, 134, 136, 146 Achlorhydria, whether due to disease, e.g., chronic atrophic gastritis, or PPI use, is a far more common cause of fasting hypergastrinemia than ZES and can lead to a false positive secretin test. 147 In one study of ZES patients 131-99% had a fasting gastric pH below 2. Therefore to exclude physiologic, appropriate hypergastrinemia caused by hypochlorhydria or achlorhydria, fasting gastric pH should be the next step if an elevated fasting gastrin level is found and ZES is suspected, See Fig 34.3. Another cause of physiologic hypergastrinemia, besides chronic atrophic gastritis and PPI use, is acid-reducing surgery such as vagotomy. 10, 40, 98, 130, 134, 136. Chronic kidney disease also causes fasting hypergastrinemia due to reduced gastrin clearance. In patients with chronic atrophic gastritis, fasting serum gastrin levels can be increased more than 70 FOLD, and in patients taking a PPI, over 25% have a more than fourfold elevated gastrin level. 134 For comparison, the majority of ZES patients have a fasting gastrin level increased by less than 10 FOLD, see Fig 34.3. Therefore no degree of serum gastrin elevation alone distinguishes ZES from patients with physiologic, appropriate hypergastrinemia. 134 Patients with elevated fasting serum gastrin levels that are less than 10 FOLD increased, i.e., 1000 pg/ml, and with a fasting gastric pH below May 2 have a condition other than ZES, such as gastric outlet obstruction, HP infection, renal failure, short bowel syndrome, enteral G cell hyperfunction or hyperplasia, or the retained gastric antrum syndrome. In such patients, secretin testing and a formal basal acid output, BAO, measurement should be considered if occult gastrinoma is suspected. 134, 142, 148 The secretin test is based on the finding that gastrinomas release 0, 5, 10, 15, 20 probability of survival, %. 190, 80, 70, 60, 50, 40, 30, 20, 10 0 years since diagnosis p 0.02 p equals 0.0004 No liver mets, n equals 158, single liver lobe mets, n equals 14, diffuse liver mets, n equals 27, 0, 10, 20, 30, 40, 50, 60, 70, 80, 90, 100 Primary gastrinoma location panduode lymph node mets liver mets p 0.0001 p equals ns 0, 10, 20, 30, 40, 50, 60, 70, 80, 90, 100 Primary gastrinoma primary size lymph node mets liver mets less than or equal to 1 cm 1.1 to 2.9 cm greater than or equal to 3 cm less than or equal to 1 cm 1.1 to 2.9 cm greater than or equal to 3 cm NSP. 0.0001% Fig 34.4 Effects of gastrinoma extent on survival and of primary gastrinoma location and size on the development of lymph node or liver metastases, METs. Left, survival in patients with ZE syndrome, with or without liver metastases. Right, upper part shows the percentage of 83 patients with primary pancreatic or duodenal gastrinomas who developed lymph node or liver metastases. Lower part shows percentage of 118 patients with primary gastrinoma of varying diameter who developed lymph node or liver metastases. Left, adapted from UF, Venzen DJ, Serrano J, ETAL prospective study of the clinical course, prognostic factors, causes of death, and survival in patients with long-standing Zollinger-Ellison syndrome. J. Clin Oncle 1999, 17:6-1530, Right, adapted from Weber H.C., Venzen D.J., Lin J.T., ETAL determinants of metastatic rate and survival in patients with Zollinger-Ellison syndrome, a prospective long-term study. Gastroenterology 1995, 108:1637-49. 482 Part 4 Topics involving multiple organs and exaggerated amount of gastrin in response to 4-secretin, likely caused by specific receptors for secretin on tumor cells. 149 A serum gastrin increase greater than or equal to 120 pg/ml after injecting 2 U/kg secretin 4 has high sensitivity, 94%, and close to 100% specificity, 100%. 150 in a hypergastrinemic patient with gastric pH below 2, no false positive secretin tests have been reported. 131, 148, 150, 152 The BAO is elevated in over 90% of patients with ZES, being above 15 milliequivalent/HR in patients without prior gastric surgery and above 5 milliequivalent/HR in patients with prior acid-reducing surgery, see Fig 34.3. 0.40, 131, 152. Gastric acid secretion is now uncommonly measured, although BAO can be measured during EGD if desired. 153. Treatment. Patients with ZES, similar to those with other malignant functional NITs, have two treatment issues. 10, 73, 94, 98, 146, 152. First, acid hypersecretion has to be controlled. Second, the gastronoma must be addressed. 10. 40, 71, 73, 96, 98, 117, 118, 152. If acid hypersecretion is not controlled, life-threatening complications of peptic disease almost invariably occur, sometimes rapidly. 10, 40, 123, 130, 134, 152, 154. Even though most patients now receive some form of gastric anti-secretory treatment prior to the diagnosis of ZES, almost 25% develop bleeding, 6% to 7% experience ulcer perforations, and 8% to 10% develop esophageal strictures. 12, 129. With improved ability to control gastric hypersecretion medically, the natural history of the tumor is becoming the major determinant of long-term survival. Fig. 34.4. 110, 126. Control of gastric acid hypersecretion. Because of their long duration of action and potency, PPIs allow once or twice daily dosing in most ZES patients, 95%, and are the drugs of choice. 10, 40, 73, 152, 155, 157. All PPIs, omeprazole, lansoprazole, pantoprazole, esomeprazole, and rabeprazole, are effective. 10, 152, 155, 156. H2RAS are also effective, although higher than conventional doses are usually required. 10, 111, 152. For most ZES patients, a PPI is usually started at a dosage equivalent to 60 mg/day of omeprazole. Sufficient anti-secretory drug needs to be given to reduce acid hypersecretion, measured during the hour prior to the next dose of drug, to less than 10 mg/hr in patients without prior gastric acid reducing surgery, or to less than 5 mg/hr in patients with prior gastric acid reducing surgery. This degree of acid suppression allows peptic lesions to heal and prevents their recurrence. Although initial lower doses of PPIs are frequently used, these higher doses are recommended because of the desirability of rapidly controlling the acid hypersecretion in ZES patients. 158. In some patients, such as those with MEN1/ZES, severe GERD, or a previous Bilroad 2 resection, a higher initial PPI dose equivalent to 60 mg twice daily of omeprazole is recommended. 98, 132, 152. Such patients require greater acid suppression, and anti-secretory drugs should be increased to control symptoms and heal all mucosal lesions, which frequently require acid suppression to 1 to 2 mg/hr or even lower. 159. Parathyroidectomy in patients with MEN1/ZES and hyperparathyroidism decreases fasting gastrin levels, decreases BAO, and increases sensitivity to anti-secretory drugs. 40, 134, 160, 161. This intervention is particularly important because, as mentioned earlier, patients with MEN1/ZES with hyperparathyroidism can be relatively resistant to PPIs. 152, 156, 157. Long-term oral anti-secretory treatment has remained effective for over 10 years without development of tachyphylaxis. 40, 111, 130, 152, 155, 157. Concerns have been raised about the safety of PPIs 162, 167, but issues such as iron deficiency from iron malabsorption and increased risks of Janet's carcinoid have not been significant in clinical series. Vitamin B12 deficiency can occur on PPI therapy and should be monitored yearly. Treatment of localized gastronoma. Most authorities recommend surgical exploration of ZES patients for a possible curative resection as long as 1. Diffuse metastatic disease to the liver is absent and 2. The patient does not have MEN 1.72, 73, 98, 117, 146, 168, 169. In patients with sporadic non-MEN1 ZES, gastrinomas were found in 92%, and 51% of these resected patients were disease-free immediately after tumor resection. 34% were disease-free after 10 years. 72 This cure rate with surgery is much higher than rates reported in many earlier studies and is, in large part, the result of finding more small duodenal gastrinomas. Performing a duodenotomy routinely at surgery identifies more tumors than other commonly used methods. 111, 117, 170, 172 The role of curative surgery in patients with MEN1/ZES is controversial because the post-resection, disease-free cure rate in such patients is below 5% if a more aggressive resection, e.g., pancreaticoduodenectomy, is avoided. 61, 71, 73, 98, 169, 173, 174 This unfavorable surgical outcome occurs because MEN1/ZES patients have multiple duodenal gastrinomas and frequently have lymph node metastases at surgery. 175 The role of surgery is controversial in part because it is unclear whether early surgical resection will alter survival in MEN1/ZES. Some recommend routine exploration in patients with MEN1/ZES, others recommend medical therapy only and no exploration, and still others recommend exploration only if larger lesions, greater than or equal to 2 to 3 cm, are found. 98, 146, 173, 176 Although pancreaticoduodenectomy can cure a high proportion of MEN1/ZES patients. 177 It is not generally recommended. 98, 146, 178 Because of adverse effects of the operation and the excellent long-term prognosis of unoperated patients with small NETs, 2 cm. Glucagonomas are rare NETs, almost always NETs, that secrete excessive amounts of glucagon and cause a distinct syndrome characterized by weight loss, glucose intolerance, anemia, and a specific dermatitis known as necrolytic migratory erythema, NME, Table 34.7. Becker et al. Described a PNET with a skin Fig 34.5 necrolytic migratory erythema, NME, in a patient with glucagonoma. NME is characterized by rapidly eroding superficial blisters. The lesions are usually localized to the buttocks, groin, perineum, elbows, hands, feet, and perioral area. Courtesy Dr. Carl Grunfeld, San Francisco, California. Chapter 34 Neuroendocrine Tumors 483 34 Rash in 1942, 179 McGarvin et al. Reported a patient with an elevated glucagon level, dermatitis, diabetes mellitus, and a PNET in 1966, 180 and Wilkinson et al. 181 described NME in 1973.181 Finally, Mallinson et al. 5 established the association of NME with glucagon-producing tumors in 1974. Pathophysiology and pathology. In contrast to insulinomas, most glucagonomas are large at the time of diagnosis, with an average size of 5 to 10 cm, range 0.4 to 35 cm, 0.12, 182 to 187 Similar to other NETs, except insulinoma, glucagonomas are usually malignant. 0.12, 182, 183, 188 The most common sites of metastases are the liver and lymph nodes, with bone and mesentery less common sites. 0.11, 182 Most, 97%, glucagonomas arise in the pancreas, and they usually, 88% to 90% of cases, occur as a solitary tumor. 185 The pathophysiology of the glucagonoma syndrome is related to the known actions of glucagon. See Chapter 4. 189 Hyperglycemia results from increased hepatic glycogenolysis and gluconeogenesis. Weight loss has been attributed to the known catabolic effects of glucagon. 185 Although taste aversion effects mediated by GLP-1, 7 to 36 amide, may contribute. 190 Whether the characteristic rash, NME, is caused by hyperglucagonemia is controversial. Prolonged hyperglucagonemia caused by glucagon administration does cause a typical rash. 12, 191, 192 It is possible that hypominocytemia, present in 80% to 90%, or essential fatty acid deficiency may be involved in the genesis of the dermatitis because, if these deficiencies are corrected, NME may improve without a change in plasma glucagon levels. The similarity of the skin lesions to those seen in zinc deficiencies has resulted in trials of zinc, with some responses. The rash may even resolve with volume repletion. Therefore, there may be several contributing factors in different patients. Hyperglucagonemia may contribute to the anemia because treatment with glucagon decreases erythropoiesis in animals. The role of glucagon in causing venous thromboembolism and psychiatric problems is uncertain. 193 Glucagon cell adenomatosis 194 may simulate the glucagonoma syndrome. 12, 195, 196 In glucagon cell adenomatosis there are many microadenomas and hyperplastic islets that stain for glucagon. Also, a homozygous P86S mutation of the human glucagon receptor was, in a single case, associated with alpha cell hyperplasia, hyperglucagonemia, and ENF-NETs. This disorder, Mauvache disease, can be reproduced in mice deficient for the glucagon receptor. 196, 197 Clinical features Glucagonomas usually occur in individuals 50 to 70 years old. 12, 90, 182, 184, 186 NME is a common manifestation, Fig 34.5, also see Table 34.7. 12, 90, 183, 185, 198, 199 Dermatitis often precedes diagnosis of the syndrome for several years. 12, 198 In 70% of patients, the skin lesion is the presenting sign of the disease and has been reported up to 3 years before the PNET is found. 200 Skin lesions may wax and wane and are often misdiagnosed. 200, 201 Characteristically, the lesion starts as an erythematous patch, typically in periorofacial or intertriginous areas, such as the groin, buttocks, thighs, or perineum, and then spreads laterally. The lesions subsequently become raised, with superficial central blistering. The top of the bullae frequently detaches or ruptures, leaving eroded areas that crust. The lesions tend to heal in the center whereas the edges continue to spread, with a crusting well-defined edge. Healing is associated with the development of hyperpigmentation. This entire sequence characteristically takes 1 to 2 weeks. The histopathology can be as varied as the clinical presentation. 11 In its classic form, early lesions demonstrate a superficial spongiosis and necrosis, with subcorneal and midepidermal bullae. Fusiform keratinocytes with pycnotic nuclei are often seen, as are mononuclear inflammatory infiltrates. 5, 12, 198, 199 Glucose intolerance or frank diabetes mellitus may precede diagnosis of glucagonoma by many years. 90, 183, 186 Profound hypomenocidemia, often less than 25% of normal, especially with glycogenic amino acids, is common. 5, 11, 90, 184, 186 And essential fatty acid deficiencies are also sometimes seen. Weight loss, often profound and associated with anorexia, occurs in most patients. 11, 90, 183, 186 Even with small, non-metastatic tumors. 5, 11, 182 Table 34.7 Clinical and laboratory features in patients with glucagonoma or VIPoma syndromes. Glucagonoma VIPoma clinical features, %. Dermatitis, 54 to 90, secretory diarrhea, 89 to 100, diabetes/glucose intolerance, 22 to 90, volume depletion, 44 to 100, weight loss, 56 to 96, weight loss, 36 to 100, glossitis/stomatitis/chylitis, 29 to 40, abdominal cramps, colic, 10 to 63, diarrhea, 14 to 15, flushing, 14 to 34, abdominal pain, 12, venous thromboembolism, 12 to 35, psychiatric disturbance, uncommon, laboratory features, %. Anemia, 34 to 85, hypokalemia, 67 to 100, hypomenocidemia, 26 to 100, hypochlorhydria, 34 to 72, hypocholesterolemia, 80, hypercalcemia, 41 to 50, renal glycosuria, unknown, hyperglycemia, 18 to 100, VIP, vasoactive intestinal polypeptide. Glucagonoma data from Mallinson CN, Bloom SR, Warren AP, ETL. A glucagonoma syndrome. Lancet 1974, 2:15, Jensen RT, Norton J.A. Endocrine tumors of the pancreas and gastrointestinal tract. In, Feldman MFL, Brandt L.J., ed. Sleisenger and Fordtran's gastrointestinal and liver disease. 8th ed. Philadelphia, Saunders, 2006. pp 625-66, Elder R., Glazer B., Frankel M., ETAL glucagonoma and the glucagonoma syndrome cumulative experience with an elusive endocrine tumor. Clin Endocrinal, Oxf., 2011, 74:5938, Kind Mark H., Sundin A., Granberg D., ETAL endocrine pancreatic tumors with glucagon hypersecretion, a retrospective study of 23 cases during 20 years. Med-Oncle 2007, 24:347, Soga J., Yakuwa glucagonomas/diabeticodermatogenic syndrome, DDS. A statistical evaluation of 407 reported cases. J. Hepatobiliary pancreat SURG 1998, 5:312-9, GYACOPJGSC glucagonomas, clinical presentation, diagnosis, and advances in management. In, Mignon M., Jensen RT, EDS endocrine tumors of the pancreas, recent advances in research and management. Frontiers in GI Research Basel, Switzerland, S. Karger, 1995, Chastain Ma. The Glucagonoma Syndrome, a review of its features and discussion of new perspectives. AMJ MedSci 2001, 321:302-306, Van Beek AP, De Haas ER, Van Vieleten WA, et al. The Glucagonoma Syndrome and Necrolytic Migratory Erythema, a clinical review. J. Endocrinal 2004, 151:531-7. VI POMA data from Jensen RT, Norton J.A. Endocrine tumors of the pancreas and gastrointestinal tract. In, Feldman MFL, Brandt L.J., ed. Sleisenger and Fordtran's gastrointestinal and liver disease. 9th ed. Philadelphia, Saunders, 2010, pp 491-522, Matukinsky Cr., J.C. VI POMAS and endocrine cholera, clinical presentation, diagnosis, and advances in management. In, Mignon M.J.R., ed. Endocrine tumors of the pancreas, recent advances in research and management. Frontiers in GI Research. Basel, Switzerland, S. Krager, 1995, pp 166-82, Song S., Shi R., Li B., ETAL diagnosis and treatment of pancreatic vasoactive intestinal peptide endocrine tumors. Pancreas 2009, 38:811-4, Adam N., Lim S.S., Ananda V., ETAL VI POMA syndrome, challenges in management. Singapore Med J 2010, 51E12932, Soga J., Yakuwa vipoma/diarrheogenic syndrome, a statistical evaluation of 241 reported cases. JEXP Clin Cancer Res 1998, 17:389-400, Jensen RD, GM carcinoid tumors and the carcinoid syndrome. Individa VTJRHS, Rosenberg S.A., ed. Cancer, Principles and Practice of Oncology. 7th ed. Philadelphia, Lippincott Williams and Wilkins, 2005, pp 1559-74. 484 Part 4 Topics involving multiple organs. Venous thromboembolism is more common in the glucagonoma syndrome than in other NITs. Mild anemia, usually normocytic and normochromic with normal serum iron, folate, and vitamin B12 levels, can respond to successful tumor therapy. Diagnosis: glucagonomas are usually suspected because of the skin rash, NME, see Fig.34.5. 190,176,179,187,198,202-205. The diagnosis of glucagonoma can be confirmed by demonstrating an increase in fasting plasma glucagon concentration, normal, less than 200 pg/ml. Most glucagonoma patients have a markedly elevated plasma glucagon level at presentation 11,12,90,183,186,206 with a mean plasma glucagon concentration of 2110 pg/ml, range 550 to 6600 pg/ml, 0.11 mild hyperglucagonemia, 200 to 500 pg/ml. Also occurs in many other conditions, such as cirrhosis, chronic kidney disease, diabetic ketoacidosis, prolonged starvation, acute pancreatitis, acromegaly, Cushing, septicemia, severe burns, severe stress, trauma, exercise, celiac disease, danazol therapy, and familial hyperglucagonemia. 10, 11, 181, 185 provocative tests for glucagonoma have been described, but none are sufficiently reliable. Treatment. Medical treatment. Initial medical treatment is directed at relieving symptoms, restoring nutritional status, and controlling hyperglycemia as tumor localization studies, discussed later, are being performed. Glucagonoma patients are generally poor operative risks. The catabolic effects of glucagon combined with glucose intolerance and diabetes mellitus can markedly affect the nutritional status of these patients. Their heightened risk of venous thromboembolism increases postoperative morbidity. SSAs have been useful in controlling symptoms in patients with glucagonoma. 182, 183, 185, 207. The rash improves with SSA treatment in most patients, with disappearance in up to 30%. Plasma glucagon levels decrease in 80% to 90% of treated patients, but into the normal range in only 10% to 20%. Surgical treatment. Surgical resection should be considered in all patients with localized tumors. 208. Unfortunately, 50% to 90% of patients with glucagonoma have metastases at the time of diagnosis. 182, 184, 209. VI POMS. The VI POMS syndrome is caused by a net that secretes excessive amounts of VIP. The syndrome is characterized by extreme watery diarrhea, hypochlorhydria, achlorhydria, and hypokalemia. See tables 34.1 and 34.7. 0.4,210. Because of the resemblance of the diarrhea fluid to that seen in cholera, the term pancreatic cholera was proposed and the acronym WDHA, watery diarrhea, hypokalemia, and achlorhydria, created. 211. VIP was suspected as the mediator of this syndrome, and the ability of VIP infusions to produce secretory diarrhea in humans at blood levels seen in patients with VI POMS was confirmed. 212. Pathophysiology and pathology. Most, 80% to 90%, of VI POMS in adults are NITs, with 42% to 75% occurring in the tail of the pancreas. 12,213, 214, VI producing SI NETs, lung cancers, or pheochromocytomas are rare. 12, 211, 213, 217. VI POMS are almost always large, solitary tumors and are often metastatic at the time of diagnosis or surgery, similar to gastrinomas and glucagonomas. In young children, 10 years old, and, rarely, in adults, 5% of adult cases, the VI POMS syndrome is caused by an extrapancreatic ganglioneuroma or ganglioneuroblastoma, tumors that are malignant in only 10% of patients. 11, 211. Almost half of VI POMS produce multiple hormones, including glucagon, somatostatin, insulin, and gastrin. 11, 16. VIP is the major mediator of the syndrome. 11, 16, 211, 218. Plasma VIP levels are usually elevated. 219 and a continuous 4 infusion of VIP in normal human subjects, achieving plasma levels similar to those seen in patients with the VI POMS syndrome, produced watery diarrhea within 6 to 7 hours. 212. VIP interacts with specific receptors on intestinal epithelial cells, leading to intestinal electrolyte and fluid secretion. See Chapter 101. 11. Flushing in patients with VI POMS has been attributed to the potent vasodilatory effects of VIP. 11. The finding that only a minority of patients with VI POMS syndrome flush, despite high plasma VIP levels, has been attributed to the fact that prolonged VIP infusions result in a gradual loss of flushing, suggesting tachyphylaxis. Severe hypokalemia is likely primarily caused by fecal K and loss, secondary hyperaldosteronism that results from volume depletion with renal K and loss, and VIP stimulation of renin release may also contribute. 11 The pathogenesis of the achlorhydria or hypochlorhydria is not entirely clear but has been attributed to the inhibitory effect of VIP on gastric acid secretion. The mechanism of the hypercalcemia is also unclear. Hyperglycemia has been attributed to the glycogenolytic effect of VIP on the liver. Clinical features: the mean age for adults with VIPomas is 42 to 51 years, range 32 to 81, 10,2 11,2 19221. In children, the mean age is 2 to 4 years old, range 10 months to 9 years. The cardinal features of the VIPoma syndrome are severe secretory diarrhea associated with hypokalemia and volume depletion, see Table 34.7. 10,2 11,2 19221. Diarrhea may be episodic 2 11,2 22 and exceed 1 L/day, usually 3 L/day. 11, 16, 2 13, 2 14. The diarrheal fluid has the appearance of weak tea and persists during fasting. 11, 16, 2 18. Most, 90%, patients have 5 or more bowel movements a day. Laboratory abnormalities in patients with VIPoma are listed in Table 34.7. 10, 2 11, 2 19221. Hypokalemia is often severe, 2.5 mol/L, at some point in the course in over 90% of patients. 12, 2 11, 2 22. Tetany may occur and has been attributed to hypomagnesemia resulting from the diarrhea. 11 If measured, hypochlorhydria occurs in many cases. Diagnosis: the diagnosis of the VIPoma syndrome requires large volume secretory diarrhea that persists with fasting and demonstration of an elevated plasma concentration of VIP. 10, 16, 2 13, 2 14, 2 16, 2 18. Diarrhea may be present for long periods prior to diagnosis. The diarrhea fluid is characteristic of a secretory diarrhea, see Chapter 16. Other diseases can cause a chronic, large volume secretory diarrhea with most of the clinical features of the VIPoma syndrome, except for a high plasma VIP level, pseudovipoma syndrome. Such patients include individuals with gastronoma 16, 40, 129, chronic laxative abuse 223, celiac disease 224, AIDS enteropathy 225, or idiopathic secretory diarrhea. 12, 16, 223, 226, 228. Elevated plasma VIP levels alone should not be the sole basis for making a diagnosis of VIPoma in a patient with diarrhea, because other conditions, e.g., prolonged fasting, IBD, small bowel resection, radiation enteritis, chronic kidney disease, nesidioblastosis 229, can occasionally elevate VIP levels. 11, 16, 230. Treatment: medical treatment. The first objective is replenishment of fluid and electrolyte losses to correct the profound volume depletion, hypokalemia, and hyperchloremic metabolic acidosis, see Table 34.7. The patients may require 5 or more L/day of FLUID11 and over 350 milliequivalent/day of potassium. 11, 16, 2 11, 2 31. Hypokalemic nephropathy with severe renal. Chapter 34. Neuroendocrine tumors 485. 34. Failure may occur. 4 Fluid and electrolyte requirements should be carefully monitored. The diarrheal output should be controlled by use of SSAs. 10, 12, 16, 98, 146, 207, 232. Octreotide controls diarrhea in 78% to 100% of patients. 10, 207, 220, 232. Octreotide continued to be effective at 6 months in 56% to 100% of patients, but 22% required an increase in dosage. 11, 12. Plasma VIP concentrations decreased in 80% to 89% of patients taking octreotide. Decreases in plasma VIP concentration with octreotide treatment did not always mirror clinical responses. 11, 16, 233. Treatment of metastatic VIPoma is discussed later. Surgical treatment: once the fluid and electrolyte deficits are corrected, patients should undergo imaging studies, discussed later, to assess tumor resectability. After performing these imaging studies, surgical cure should be considered for all patients without metastatic disease. 10,98,105,208,214,222 Surgical resection of a pancreatic VIPoma relieves all symptoms in 1/3 of patients, and up to 30% of them are cured. 12,211,234 in children, and rare adults, with VI-producing ganglioneuroblastomas. 12 Surgical resection with control of all symptoms was possible in 78% of patients. Other functional NITs. Less common NITs are summarized in Table 34.1. ACTH-producing NITs can cause Cushing syndrome. These tumors are often metastatic, aggressive, and refractory to treatment including SSA therapy. 10,11,235,236 NITs secreting PT-related peptide causing hypercalcemia are usually large and/or metastatic to the liver by the time of diagnosis. In addition to anti-tumor treatment, bisphosphonates can be used to control the hypercalcemia. 237 Serotonin-producing NITs can cause the carcinoid syndrome and are rare, usually large, and predominantly malignant. 12,13,188 The term somatostatinoma is sometimes used to describe rare pancreatic or duodenal tumors which secrete large amounts of somatostatin, resulting in relatively nonspecific symptoms such as diabetes mellitus, gallstones, diarrhea/steatorrhea, and weight loss. The term is also sometimes used to describe duodenal nets which stain positively for somatostatin and are also characterized by samoma bodies, but do not necessarily secrete somatostatin. Such tumors are seen with increased frequency in NF1 patients. Due to the relatively subtle clinical manifestations of the somatostatinoma syndrome, this diagnosis is exceedingly rare. 238 Non-functional NITs. A non-functional PNET, ENFNET, is a PNET that is not associated with secretion of a peptide/amine causing a functional syndrome, and whose symptoms are entirely caused by the local effects of the tumor itself. 12 Clinical features. The typical patient with a well-differentiated ENFNET is 40 to 60 years old. The median time from initial symptoms to diagnosis varies from 6 months to almost 3 years. Increasingly, small ENFNETs are diagnosed incidentally as patients undergo scans for unrelated reasons. Presenting symptoms/signs from the tumor include abdominal pain, jaundice, and weight loss. 10,25,29,67,239,241 Treatment. Surgical resection is generally recommended for patients with localized, resectable NF-NITs. Future relapse is dependent on tumor size, grade, and lymph node positivity. The treatment of patients with small, less than or equal to 2 cm, sporadic, incidentally diagnosed low-grade NF-PETs is controversial. 67 Several studies show high rates of disease stability in patients undergoing surveillance. 242 Certain radiographic features suggestive of indolent behavior include well-defined tumor borders and tumor homogeneity. 243 Ultimately, decisions regarding surgery versus surveillance need to factor patient age, comorbidities, and willingness to undergo long-term surveillance. 67, 244,245. GI nets, carcinoids, GINETs, carcinoid tumors, comprise nearly 70% of all carcinoid tumors. Most of the others, 25%, are found in the respiratory tract. GINETs most commonly occur in the small intestine, rectum, appendix, or stomach. Table 34.8. 246 Within the small intestine, the ileum is the most common site, followed by the duodenum and jejunum. 246 The incidence of GINETs is increasing, but not evenly so. See Fig 34.1. 23 Survival is highly dependent on the tumor stage. 247 as shown for selected GINETs in Table 34.9. Gastric nets. Gastric nets comprise 0.3% of all gastric tumors and 2% to 6% of all carcinoid tumors in the U.S. Their incidence has increased markedly over the last 30 years, see Fig 34.1. 0.247260. It is unclear whether this is a true increase in disease incidence or due to Table 34.8 relative frequencies of selected carcinoid tumors and their prevalence of metastases and carcinoid syndrome. % of all carcinoids, % with metastases, % with carcinoid syndrome. Gastric 2 to 6, 22 to 31, 10 small intestinal 10 to 28, 14 to 71, 3 to 13 appendiceal 2 to 38, 2 to 35, 1 colonic 4 to 10, 60 to 71, 5 rectal 10 to 19, 3 to 14, 1a other. Less common sites for carcinoids not included here include esophagus, liver, gallbladder, biliary tract, larynx, cervix, ovary, and testis. B. Small intestine includes duodenum, ampulla, jejunum, ileum, and Meckel diverticulum. Data from Yao J.C., Hassan M., Fan A., et al. 100 years after carcinoid, epidemiology of and prognostic factors for neuroendocrine tumors in 35,825 cases in the USA. J. Clin-Oncle 2008, 2630-6372, Maudlin I.M., Like A.D., Kid M. A 5-decade analysis of 13,715 carcinoid tumors. Cancer 2003, 97:93459, Maudlin I.M., Sander A. An analysis of 8,305 cases of carcinoid tumors. Cancer 1997, 79:1329, Godwin J.D. Second, carcinoid tumors. An analysis of 2,837 cases. Cancer 1975, 36:569. Other studies may vary, see text. Table 34.9 Median survival, months, of selected carcinoid tumors by stage: localized stage, regional stage, distant stage. Gastric 154, 71, 29, small intestinal 111, 105, 103, appendiceal greater than 360, greater than 360, Na colonic 261, 36, 14, rectal 290, 90, 34. Data from Dasari A., Shen C., Halperin D., ETAL. Trends in the incidence, prevalence, and survival outcomes in patients with neuroendocrine tumors in the USA. JAMA Oncle 2017, 3:133542, Yao J.C., Hassan M., Fan A., et al. 100 years after carcinoid, epidemiology of and prognostic factors for neuroendocrine tumors in 35,825 cases in the USA. J. Clin-Oncle 2008, 2630-6372. N.A., not available. 486 Part 4 Topics involving multiple organs. Improved detection from increased use of EGD. 248 Thus, gastric nets are now often found by chance during EGD performed for some other reason. 118, 250, 251, 253, 257, 258, 260. Gastric nets are classified into three types, Table 34.10. For correct classification of gastric carcinoids into these types, the mucosa of the gastric antrum and the body/fundus should both be sampled, in addition to the removal or biopsy of the lesions. 146, 248, 250, 260. Type 1 gastric nets, the most common type, are generally small and multiple and occur in patients, more often women, with chronic atrophic gastritis with or without pernicious anemia. 248250, 260. Type 1 gastric nets occur in 1% to 2% of patients with chronic atrophic gastritis. See Chapter 52. 253 At EGD, type 1 gastric nets usually appear as polypoid lesions associated with mucosal atrophy, Fig 34.6a. 253 If random mucosal biopsies are taken, additional intramucosal nets will be found, though not seen at endoscopy. 253 Histologically, type 1 gastric nets are well differentiated and always associated with varying degrees of gastric ECL cell hyperplasia. ECL hyperplasia is driven by hypergastrinemia caused by loss of the feedback inhibition by gastric acid on gastrin, G, cells, see Chapter 51. 249 Chronic hypergastrinemia, often profound, results in increasing degrees of ECL cell hyperplasia, diffuse, linear, micronodular, and, in some cases, dysplasia, and then neoplasia. 249 Type 1 gastric nets are generally minimally invasive, with 27% limited to the mucosa and 64% limited to the submucosa. Only 9% invade the muscularis propria. 257,260. Metastases to lymph nodes or liver are very uncommon. 22,248,261 Type 2 gastric nets are the least frequent type and occur almost exclusively in patients with MEN1/ZES. 61,114,116,250,258 They occur in 23% to 33% of patients with MEN1/ZES, invariably with hyperparathyroidism. 61,68,116,160 Type 2 gastric nets have only rarely been described in patients with the sporadic form of ZES. 68,114,116 Type 2 gastric nets are, like Type 1, generally multiple, but they tend to be larger, with only 35% smaller than 1 cm and as many as 20% larger than 2 cm. See Fig 34.6b. Type 2 gastric nets generally appear as polypoid lesions, although they too can be detected on blind biopsies as intramucosal tumors. 116,250 They are well differentiated, always associated with ECL cell hyperplasia and a hyperplasic gastric mucosa. 114,116,250,258 Type 2 gastric nets are somewhat more invasive than Type 1, with 15% showing invasion limited to the mucosa, 60% extending into the submucosa, and 10% into the muscularis propria. Metastases are also more common in Type 2 than Type 1. 116,250,257,260 and the 5-YEAR survival in patients with Type 2 gastric carcinoids is lower than in Type 1, see Table 34.10. However, it is unclear whether this lower survival is due to the gastric nets per SE 61,68,250. Type 3 gastric nets differ from the other two types in that they are not associated with hypergastrinemia or alterations in gastric acid secretion. They are solitary, sporadic nets not associated with other diseases of the stomach, see Fig 34.6c. 248,257,258,260 Endoscopically, Type 3 gastric nets are usually single, large, infiltrating lesions that in some cases are ulcerating, see Fig 34.6c. Histologically, they are generally well differentiated nets, see Table 34.2a. Patients with Table 34.10 Types of gastric carcinoids. Type 1, Type 2, Type 3 Relative frequency, %. 65 to 85 to 614 to 25 Gender female male female equals male male female Tumor features, size of tumor, cm, 1, 80%. 1 to 2, 15% 20%, greater than 2, 1%, 1, 35%. 1 to 2, 45%, greater than 2, 20%. 2 to 5 Number of tumors. Multiple single histology, grade, G, well differentiated, G1 well differentiated, G1 well differentiated, G1 or G2 ECL cell hyperplasia, %. 100 0 Gastric mucosa atrophic hyperplastic normal associated conditions gastric atrophy MEN/ZES none gastric pH, acidity level high pH, anacidity low pH, hyperacidity normal pH and acidity fasting serum gastrin high normal metastases, lymph nodes, %. 2 to 9 15 to 30 75 to 100 distant, %. 0 to 2 10 50 to 100 tumor-related death, %. No 10 25 to 35 years survival, disease-related, %. 160 to 90 50 treatment 1 cm, ender 1 to 2 cm, ender or surgery greater than 2 cm, surgery 1 cm, ender 1 to 2 cm, ender or surgery greater than 2 cm, surgery, with removal of regional lymph nodes, if no advanced disease, ender, endoscopic resection, MEN/ZES, multiple endocrine neoplasia type I/ZES. Data from Del Fave G, Kwekabom DJ, Van Kutsami, ETAL and its consensus guidelines for the management of patients with gastroduodenal neoplasms. Neuroendocrinology 2012, 95:7487, Lawrence B., Kid M., Svejda B., ETAL. A Clinical Perspective on Gastric Neuroendocrine Neoplasia. Cur Gastroenterol Rep 2011, 13:1019, Del Fave G., Capisso G., Million M., ETAL Endocrine Tumors of the Stomach. Best Pract Residential Clin Gastroenterol 2005, 19:65973, Scarablo H., Kadiat G., Jensen RT, ETAL, Neuroendocrine Tumors of the Stomach, Gastric Carcinoids, are on the rise, Small Tumors, Small Problems? Endoscopy 2010, 42:66471, Rindi G., Aitzen IC, La Rosa S., ETAL ECL cell tumor and poorly differentiated endocrine carcinoma of the stomach, prognostic evaluation by pathological analysis. Gastroenterology 1999, 116:53242, Rindi G., Bordy C., Rappel S., ETAL gastric carcinoids and neuroendocrine carcinomas, pathogenesis, pathology and behavior. World JSURG 1996, 20:16872, Rusniewski P., Del Fave G., Kadiat G., ETAL well-differentiated gastric tumors/carcinomas. Neuroendocrinology 2006, 84:15864. Chapter 34 Neuroendocrine Tumors 487 34 Type 3 gastric nets may have signs of GI bleeding or advanced malignancy, prompting EGD.260 at the time of diagnosis. Most type 3 gastric carcinoids are already invasive. The 5-YEAR survival rate is close to 50%, and 25% to 30% of type 3 patients have a tumor-related death. 248, 257, 258, 260. The carcinoid syndrome, discussed later, occurs in a small percentage of patients with type 2 and type 3 gastric nets. 248, 251, 255. An atypical flush may occur in these patients because these gastric nets may lack lamino acid decarboxylase, and thus instead of producing serotonin, they secrete its unprocessed precursor, 5-hydroxytryptamine, 5-HTP, Fig 34.7, 248, 251, 256. The atypical flush is a prolonged red-purple flush involving the trunk and extremities. 248, 256. The more typical carcinoid flush is shown in Figure 34.8. Rare gastric nets can also release histamine, which can result in bronchospasm, itching, cutaneous flushing, and lacrimation. 259. The minimal laboratory evaluation in type 1 and type 2 gastric carcinoids is an assessment of serum gastrin. In patients suspected to have type 1 gastric nets with chronic atrophic gastritis, the clinician should consider ordering a complete blood count, parietal cell antibodies, serum B12, see chapters 51 and 52, and thyroid function tests, for possible associated autoimmune thyroiditis. 250. In patients with possible MEN1/ZES, a full assessment for the features of MEN1 should be performed. For all gastric nets larger than 1 cm and for localized type 3 nets, EUS should be performed to assess the depth of invasion prior to endoscopic removal. 248, 250. The overall 5-YEAR survival rate for all types of gastric carcinoids in the US SEER database is 49%, see Table 34.10, but these data include only primarily malignant tumors, therefore it is likely that many type 1 gastric carcinoids, with better survival, were not included. Types 1 and 2 gastric nets share many similar management aspects that differ markedly from the approach for type 3 carcinoids, see Table 34.10. Small, 1 cm, type 1 and 2 carcinoids should in most cases be treated endoscopically. 248 for type 1 or 2 gastric carcinoids. Fig 34.6 endoscopic images of the 3 types of gastric carcinoids. A. Type 1, in patient with chronic atrophic gastritis, CAG, and pernicious anemia, PA. Note the pale atrophic mucosa and multiple small carcinoids. B. Type 2, in a patient with MEN-I/ZES. Note the multiplicity of lesions and prominent gastric folds. C. Type 3, which is characteristically solitary and often large. Modified from Skirablu H, Kadiat G, Jensen RT, ETAL. Neuroendocrine tumors of the stomach. Gastric carcinoids are on the rise. Small tumors, small problems. Endoscopy 2010, 42:66471. A type 1 gastric carcinoid, PA, CAG, type 2 gastric carcinoid, MENI, ZES, type 3 gastric carcinoid, sporadic. BC 488. Part 4. Topics involving multiple organs that infiltrate to the submucosa. It is recommended that endoscopic mucosal resection, EMR, be considered, although many are still treated with traditional polypectomy. 248,254 EGD surveillance should be at least yearly. In 1 STUDY253 of patients with type 1 gastric carcinoids treated endoscopically, survival was 100% during the 4-6 month follow-up. No metastases occurred, a single patient developed a less differentiated tumor requiring surgery, and 64% had a recurrence after a median of 8 months, treated endoscopically. Thus, endoscopic management was safe and effective. For type 1 and 2 gastric carcinoids 1 to 2 cm in size, there is not complete agreement on the best treatment. 248,254 Most commonly, after EUS assessment of depth, these lesions are removed endoscopically. 248,250, 252, 253, 260. Although some authors recommend surgical therapy. 248,249, 260 in patients with high-risk tumors, e.g., size 2 cm, relatively high Ki-6-7 index. A surgical wedge resection can be considered. 248 Long-term treatment with an SSA may result in disappearance of small, 1 cm. Gastric carcinoids. 248, 250, 260 in patients with numerous type 1 gastric carcinoids. Antrectomy eliminates the hypergastrinemia driving ECL cell growth and is effective in over 80% of patients. 260 Patients with type 3 gastric NETs require imaging for disease staging, discussed later. If distant metastases are not present, these patients should be managed surgically. 248, 250, 260 Some recommend that the rare small, 1 cm, type 3 gastric carcinoid without any risk factors may be treated conservatively by endoscopic mucosectomy. 262 Patients with advanced metastatic gastric carcinoids of type 1, rare, 2, uncommon, or 3 require systemic anti-tumor therapies, as discussed later. Poorly differentiated gastric NETs of the stomach comprise 3% to 8% of all gastric carcinoids. 248 They are generally solitary larger tumors, greater than 2 cm. They are associated with metastases in 80% to 100% of cases, and over 50% of patients have a tumor-related death. 248 These tumors are treated like other poorly differentiated GINETs in other locations, see later. 263, 264 Small intestinal NETs, jejunal/ileal carcinoid tumors. The incidence of SI NETs is increasing in the US, see Fig 34.1. SI NETs comprise more than half of all SI neoplasms. 265 In this chapter, we use the term SI NET to refer to jejunal and ileal NETs, also known as midgut NETs. Duodenal NETs are discussed later. The average age at presentation of patients with SI NETs is in the 6th decade of life. 266 These tumors occur less frequently in Asians and more frequently in African Americans. 24 There are rare families with ileal NETs that appear to have autosomal tryptophan 5-hydroxytryptophan, 5-HTP, 5-hydroxytryptamine, 5-HT, serotonin, 5-hydroxyindoleacetaldehyde, 5-hydroxyindoleacetic acid, 5-HIAA, ho-tryptophan 5-hydroxylase aromatic L-amino acid decarboxylase monoamine oxidase aldehyde. Dehydrogenase excreted in urine HNHCC NH2HCOOHHH NH2HCC NH2HCOOHHCC ho 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 HC CHO HHC COOHH Fig 34.7 Synthesis and degradation of serotonin, 5-hydroxytryptamine 5-HT. Shown are the various enzymes that are important in the synthesis of serotonin from tryptophan and its degradation to 5-hydroxyindoleactic acid, 5-HIAA, which is excreted in the urine. Chapter 34 Neuroendocrine Tumors 489 34 Dominant Inheritance. Their tumors are similar clinically to sporadic cases and share frequent aberrations in chromosome 18.267. Many fewer nets occur within the jejunum, 9% to 18%. Than within the ileum, 70% to 87%, with 40% to 70% of the latter occurring within 2 feet of the ileocecal valve. 246,266 SI nets are generally small, with 1/3 less than 1 cm, another third 1 to 2 cm, and the final third larger than 2 cm, with 8% greater than 5 cm. 22,266 Approximately 25% are multifocal. 233,268,269 SI nets, although characteristically well differentiated, are often quite invasive. Only 28% are confined to the mucosal/submucosal, and 52% extend to the muscularis propria or R. Transmural. Metastases occur in the majority of patients with SI nets, range 20% to 100%, 22,233,266,268 usually to the liver, lymph nodes, mesentery/omentum/peritoneum, lung, or bone. 22,30,266,270,278 Large central mesenteric lymph nodes, often with surrounding desmoplasia, are highly characteristic of SI nets and generally indicative of a SI origin, even when the primary tumor is occult on scans. SI nets are thought to arise from enterochromaffin cells, EC, cells. They are predominantly well differentiated, G1, tumors, with 9% to 19% of them G2 and 2% G3.271. Numerous genetic/epigenetic changes have been reported in SI nets, including loss of 3p13, associated with better survival, and gain of chromosome 14, associated with worse survival. 279 Although SI carcinoids characteristically are diagnosed in the 6th decade of life. 266 The diagnosis is often delayed 4 to 5 years from symptom onset, and even much longer delays have been reported. 22,272 Most 90% patients present with symptoms that are either related to tumor or to carcinoid syndrome, discussed later. Tumor-related symptoms include abdominal pain, often intermittent, crampy. Recurrent cases of bowel obstruction may also occur, either due to primary intestinal tumor or mesenteric metastases. Weight loss and hepatomegaly are other signs/symptoms associated with these tumors. Symptoms of carcinoid heart disease, dyspnea, edema, are often late manifestations of disease. 22,265,266,280,281 Treatment of patients with SI nets first requires staging the extent of disease by imaging studies and also determining whether the carcinoid syndrome is present, both discussed later. 105,265,282 Curative resection of the primary net and adjacent lymph nodes improves the 5-YEAR survival rates in patients with local or locoregional SI nets. 277 Lymph node involvement around the superior mesenteric artery may require lymph node dissection. 265,282 Surgical resection of the primary net, even in the presence of distant metastases, is often recommended, discussed later. At the time of surgery, a cholecystectomy is usually performed because many patients will subsequently be treated with SSAs that often cause biliary sludge and gallstones. 265,282 The overall 5-YEAR survival of patients with metastatic SI nets is approximately 70%. 283 with a median survival of 8 to 9 years. 270,272,273 Survival is very much dependent on the stage of the disease. See Table 34.9. Prognostic factors for reduced survival in patients with SI nets include male gender, older age, metastases, carcinoid syndrome, especially with carcinoid heart disease, and highly elevated urine 5-HIAA levels. 22,270,272,274,276,278,284 In contrast to many other nets, the size of the primary SI net does not correlate well with biological activity. For example, about 46% of tumors smaller than 1 cm are associated with liver metastases. 22,272,278 Appendiceal nets, carcinoids. Appendiceal nets comprise 32% to 80% of appendiceal tumors and, in different series, represent 2% to 38% of GINETs, carcinoid. See Table 34.8. Patients with appendiceal nets tend to be middle-aged, mean age, 38 to 51 years, 265, 285, 286. These tumors are less common in males than females and less common in Asians than other races. 3 to 9 appendiceal nets are found for every 1,000 appendectomies. 22, 24, 233, 246, 265, 285, 287. Most, 95%, are typical carcinoids. A separate type of appendiceal malignancy, adenocarcinoid, also known as goblet cell carcinoid, is entirely distinct in clinical behavior and treatment. Most appendiceal nets occur at the tip of the appendix, 60% to 75%, with 5% to 20% found in the body and 7% to 10% at the base of the appendix. 265, 287. The majority of them, 60% to 80%, are less than 1 cm in diameter, 5% to 25% are 1 to 2 cm, and 2% to 17% are larger than 2 cm. 265, 287. Appendiceal nets are usually well differentiated, G1, tumors, 87%, with the remainder well differentiated G2 tumors, 13%. 288 Poorly differentiated G3 appendiceal neuroendocrine carcinomas are uncommon, 1%. 288 Nearly all appendiceal nets are discovered incidentally during appendectomy for appendicitis or other reasons. The appendiceal carcinoid only rarely causes the appendicitis. 265 In contrast to SI nets, appendiceal nets very rarely cause the carcinoid syndrome. See Table 34.8. 265 Low-grade nets in the tip of the appendix measuring 2 cm in size are almost never associated with malignant behavior. 289 The primary risk factor for locoregional or distant metastases is tumor diameter greater than 2 cm. Other negative prognostic factors include location of the tumor at the base of the appendix, greater than 3 mm invasion into the mesoappendix, high-grade tumors, and positive resection margins. 265, 282 The 5-YEAR survival rate for patients with localized disease is 88% to 100%, with regional involvement, 78% to 100%, and with distant metastases, 12% to 34%, see Table 34.9. 24, 265, 282, 288 Because the diagnosis of an appendiceal net is most frequently made as an incidental finding in the surgical specimen after appendectomy, cross-sectional imaging studies may have been performed preoperatively to evaluate abdominal pain. 105, 265 However, if cross-sectional imaging, e.g., CT, MRI, had not been performed preoperatively, it is not recommended postoperatively if the appendiceal net is less than 1 cm in diameter. In a patient with a 1 to 2 cm tumor, imaging studies can be considered to rule out the possibility of Fig 34.8 carcinoid flush. Typical carcinoid flush involving the face and neck in a patient with small intestinal carcinoid and the carcinoid syndrome. 490 Part 4 Topics involving multiple organs. Additional locoregional disease or distant metastases, even if the resection was complete. 265 Appendiceal nets larger than 2 cm, with significant mesoappendiceal infiltration, and/or with vascular invasion require radiographic staging studies. 265, 290 The same approach is also recommended in cases where completeness of resection is unclear or metastases are present. 265 Treatment of appendiceal nets is primarily surgical, but the choice of operation depends on several factors. For typical tumors 1 cm or smaller without gross metastases, with tumor invasion no deeper than the subserosa, with minimal, LOV, MM, mesoappendiceal invasion, and with clear surgical margins, a simple appendectomy is sufficient. 265, 282, 287. Fortunately, these strict criteria apply to the majority of typical appendiceal nets. 285 of 103 such patients treated with a simple appendectomy and followed for at least 5 years, 83 of them for 10 to 35 years, no patient developed a local recurrence or metastatic disease. 291 in the rare case where the appendiceal net is at the base of the appendix, if more than 3 mm of mesoappendiceal invasion is present, or if the excision is incomplete, right hemicolectomy should be considered. 265 for appendiceal carcinoids 1 to 2 cm in diameter and, therefore, T2, NETs, or T1b, UICC/AJCC, lesions, there is not complete agreement on the best treatment. 265 some recommend a right hemicolectomy, whereas others recommend a simple appendectomy. 22, 265, 287, 291 NETs guidelines propose that additional criteria be used, namely location and local invasion of the tumor. 265 if the tumor is located in the base of the appendix or if there is mesoappendiceal invasion of more than 3 mm, a right hemicolectomy is recommended. 265 for appendiceal carcinoid tumors larger than 2 cm in diameter that are T3/T4, NETs, or T2b or greater, UICC/AJCC, most authorities 265, 287, 291 but not all. 292 recommend a right hemicolectomy. Treatment of patients with distant metastases is discussed later. Rectal nets, carcinoids, rectal nets are increasing in incidence, see Fig 34.1. 24, 293-296. It is unclear whether there is a true increased incidence of these tumors or simply better detection because of widespread use of lower GI endoscopy for cancer screening and other indications. 295 Earlier detection of rectal carcinoid tumors may explain the decreasing size of the typical rectal net over the past decades. 295 Rectal carcinoids are found in 1 in every 1,500 to 2,500 proctoscopies/ colonoscopies. 233, 295 In the U.S., rectal nets are especially common in Asian Americans and less common in Caucasian Americans, with African Americans having an intermediate incidence. 246 In studies from Japan and other Asian countries, rectal nets account for 60% to 90% of all GINETs. 297, 298 Rectal nets are often diagnosed in the 6th decade of life and are usually asymptomatic. 246, 294, 295, 298302 The carcinoid syndrome is very uncommon, 0.7%, in patients with rectal nets, see Table 34.8. 293,302 Rectal nets are characteristically small, mean diameter, 0.6 cm, polypoid lesions that occur on the anterior or lateral walls of the rectum 4 to 13 cm above the dentate line. 302 Most, 98%. Rectal carcinoids are well differentiated nets that are NETs/WHO grade G1, 72%, or grade 2, 28%. 293, 300, 302 Nearly 80% of tumors invade no deeper than the submucosa, with some invading into the muscular layer, 10%, transmurally, 7%, or into neighboring structures, 5%. 302 Metastases from rectal nets are related to size, those that are less than 1 cm in diameter, the majority, rarely metastasize, 2% to 5%. 302 In contrast, the metastatic rate for tumors that are 1 to 2 cm is 5% to 30%. And the metastatic rate jumps to 60% to 80% for the 15% that exceed 2 cm. 246, 302 The pooled incidence of metastases from rectal nets in the U.S. is 22.6%, with lymph node, liver, bone, mesentery/omentum/peritoneum, and lung the leading sites. Using AJCC-TNM staging, 81% of rectal carcinoids are stage I, 5% stage 2, 11.5% stage 3, and 2.5% stage 4.301 Overall 5-YEAR survival with rectal nets is 88%, with survival very much dependent on the stage of the disease, see Table 34.9. 246, 293, 299, 300. Risk factors for more advanced disease and worse survival include larger primary tumor size, particularly greater than 2 cm, increased depth of invasion, poor differentiation, elevated key proliferative index, neural, lymphatic, or vascular invasion, and nodal, hepatic, or distant metastases. 293, 299, 300. If the rectal net is relatively large, greater than 2 cm, advanced stages are likely and cross-sectional imaging, CT or MRI, as well as somatostatin receptor imaging are indicated for staging. 293. Rectal EUS is also important for assessing tumor size, depth of invasion, and lymph nodes. 293, 303. Treatment of rectal nets depends on their size, level of invasion, and stage. 293, 295, 299. For tumors less than 1 cm in diameter that do not infiltrate into the muscularis propria or show lymphovascular invasion or lymph node metastases, endoscopic excision is recommended. Standard polypectomy can usually be performed, but if local mucosal/submucosal invasion is present, a more extensive endoscopic procedure may be appropriate, e.g., EMR or submucosal dissection. 293, 295, 299. For rectal carcinoids 1 to 2 cm in diameter, the preferred treatment is a matter of dispute, with some recommending endoscopic removal and others more aggressive treatment. 293, 295, 304. These tumors have a metastatic rate of 10% to 15% compared to 3% in patients with rectal carcinoids smaller than 1 cm. 246, 293. Because some studies show no added benefit of more aggressive treatment, guidelines recommend that patients with 1 to 2 cm rectal nets with a low mitotic rate and without invasion into the muscularis propria on EUS undergo local endoscopic resection. 118, 250, 293. For rectal nets greater than 2 cm in diameter, with their much higher metastatic risk of 60% to 80%. 246, 293. It is generally recommended that patients be treated like patients with rectal adenocarcinoma. Especially if the neoplasm is a T3 or T4 lesion, the tumor is grade G3, or if locoregional lymph node involvement is present, with total mesorectal excision or abdominoperineal resection, depending on the distance from the tumor to the anal verge. See Chapter 127. 293, 299. Treatment of patients with metastatic disease is discussed in a later section. Duodenal and ampulla of Fata nets, carcinoids. Duodenal nets have an annual incidence of 0.19/100,000 in the US. 24. They comprise 5% of all GINETs. 24, 250. Their incidence is lower in England. 296 and higher in Japan, where they comprise 10% of all GI nets and were found in almost 10% of autopsies. 118, 305. Most 90% duodenal nets arise from the first or second part of the duodenum, with 18% to 20% occurring in the periampullary region. 305, 306. Duodenal somatostatinomas and gangliocytic paragangliomas show a preference for the ampullary region, and the former may be particularly associated with NF1, see Table 34.3, 61, 118. In fact, 25% of all ampullary nets are associated with NF1.307. Duodenal nets are generally small, with a mean diameter of 1.2 to 1.5 cm, 75% of them are smaller than 2 cm. 305. Most, 63%, are limited to the mucosa or submucosa, but they still can metastasize to lymph nodes, 19% to 60% of cases, although liver metastases occur in less than 10%. 118,250,295,299,305. Most duodenal carcinoids are solitary, but they are multiple in 9% to 13%, particularly in patients with MEN1, who comprise 6% of all patients with duodenal nets. 118, 250, 306. For example, in MEN1/ZES patients, 80% to 90% of gastrinomas are in the duodenum, and they invariably are multiple. 61, 68. Chapter 34. Neuroendocrine tumors. 491. 34. Duodenal nets can be divided into 5 subtypes: duodenal gastrinomas, 48% to 66%, somatostadenomas, 15% to 43%, non-functioning NETs, i.e., not associated with a clinical syndrome, 19% to 27%, gangliocytic paraganglioma, 2%, and poorly differentiated neuroendocrine carcinomas, 3%, 0.40,118,247. Many studies also differentiate NETs in the ampulla of Fata region or periampullary area from other duodenal NETs. 0.118,250,306. Carcinoid syndrome is almost never observed with duodenal NETs. 0.12 Duodenal somatostadenomas may contain psammoma bodies. 0.118,305 Duodenal gangliocytic paragangliomas contain epithelial, ganglia, and spindle cells and stain for S100 protein immunoreactive Schwann cells. 0.118 The mean age at presentation is the 6th decade, with a slight male predominance. 0.118,250,305,306,308 Because the vast majority of duodenal NETs are not associated with a clinical syndrome, they are usually diagnosed during EGD for nonspecific symptoms. 0.118,250,305,306,309 The most frequent functional syndromes are ZES, 10%, and carcinoid syndrome, 4%. Other syndromes, see Table 34.1, are rare, 1%, 0.250. Periampullary NETs most often, 50% to 60%, present with jaundice and may also cause pain, nausea/vomiting, and diarrhea. 0.118,250,307 The 5-YEAR survival rate in patients with well-differentiated duodenal NETs is 80% to 95%. 5-year survival for those with duodenal gastrinomas is above 90%. 0.72,126 Poor prognostic factors include distant metastases, advanced stage, larger primary tumor size, depth of invasion into the muscularis mucosa or beyond, increased mitotic activity, and poorer differentiation. 0.247,305,306 Ampulla of Fata NETs may show different growth characteristics than other duodenal NETs, as the size of the ampullary net does not correlate with the development of liver metastases. 0.247 EGD with biopsies is the most common method to diagnose duodenal NETs, and it should be followed by EUS to assess the level of invasion. 0.250 for patients with suspected or proved advanced disease, CT or MRI, and somatostatin receptor imaging are indicated. Treatment is based on size, location, and type of NET, small, less than or equal to 1 cm. Non-ampullary duodenal NETs can be removed endoscopically if no metastases are present and tumor invasion is limited to the mucosa or submucosa. 0.118,247 However, if the duodenal NET is located in the ampullary region, surgical resection with lymphadenectomy is recommended. For intermediate-sized, 1 to 2 cm, duodenal NETs, surgical treatment is generally recommended. 0.118,310,313 Large, greater than 2 cm, duodenal NETs, or one of any size with lymph node involvement, should be treated by surgical resection. 0.247 For patients with sporadic, non-MEN1, ZES and duodenal gastrinomas, surgical exploration with duodenotomy and resection, rather than endoscopic treatment, is recommended because the duodenal gastrinomas are almost always submucosal, and lymph node metastases are present in at least half of cases. 0.71,118,172 For the minority of patients with a functional hormonal syndrome from a duodenal NET, specific therapy should be given to control symptoms, as discussed earlier. Colonic NETs, carcinoids, colonic NETs, excluding those in the rectum and the appendix, occur with an annual incidence of 0.06 to 0.19/1,000,000.24,293,296 Colonic NETs represent 11% of all GI NETs. 0.246 The majority of colonic NETs occur in the cecum, with the remainder arising in the ascending, transverse, descending, and sigmoid colon, 11%, 8%, 4%, and 9%, respectively. 0.314 Cecal NETs belong to the midgut NET category and are often associated with carcinoid syndrome when metastatic. Colonic NETs tend to be large with more than half greater than 5 cm. 314 These tumors are often malignant, with metastases to lymph nodes, 55%, liver, 53%, mesentery/omentum/peritoneum, 24%, lung, 8%, and bone, 4%, already present at the time of diagnosis. 293,299,314 Only 14% are limited to the mucosa/submucosa, another 10% have invasion into the muscularis propria. The remaining 76% having transmural invasion or involve adjacent structures. 314 The overall 5-YEAR survival rate of patients with colonic NETs is 33% to 70%, and survival varies considerably by stage. See Table 34.9. 293,314 A worse prognosis is associated with older age, lymph node and/or distant metastases, poor tumor differentiation, larger tumor size, deeper tissue invasion, and histologic atypia. 293,314,315 The mean age of presentation is 55 to 65 years with a slight male predominance. 293,314 Increasingly, colonic NETs are asymptomatic and found on cancer screening colonoscopy. Carcinoid syndrome occurs in 5% to 12% of patients with colonic NETs, primarily originating in the cecum. 314,315 Most localized colonic NETs should be treated surgically with appropriate lymphadenectomy. Exceptions are very small, superficial, and low-grade tumors. 293,315 Treatment of patients with distant metastases is discussed later. Carcinoid syndrome The carcinoid syndrome develops in approximately 8% of patients with GINETs, range 2% to 18%. 233,316,335 Its symptoms are summarized in Table 34.11, predominantly in patients with metastatic SI, midgut, NETs. Pathophysiology The carcinoid syndrome occurs when sufficient concentrations of hormonal products released by the tumor reach the systemic circulation. Its occurrence and severity are related to the tumor size in areas that drain into the systemic circulation. In more than 90% of cases, this syndrome occurs with metastatic disease, especially to the liver. 22,233,335,338 Patients may develop a typical or an atypical carcinoid syndrome. 233,321,339 In the typical syndrome, hydroxylation of tryptophan to 5-hydroxytryptophan, 5-HTP, is the rate-limiting step, see Fig. 34.7. Once formed, 5-HTP is converted rapidly to 5-hydroxytryptamine, 5-HT, or serotonin, by aromatic lamino acid decarboxylase. Serotonin is either stored in the tumor's neurosecretory granules or released into circulation, where most of it is taken up and stored by platelets. A small amount of 5-HT remains in the circulation, where most of it is converted to 5-hydroxyindole acetic acid, 5-HIAA, by monoamine oxidase and aldehyde dehydrogenase. The 5-HIAA so produced is then excreted in urine. 233,321,340 In the atypical carcinoid syndrome, the tumor is thought to be deficient in aromatic lamino acid decarboxylase. Thus, the NET cannot convert 5-HTP to 5-HT, serotonin, and the 5-HTP is secreted into the circulation. 256,321,340 Plasma serotonin levels are normal in this situation, but urinary 5-HT levels are usually elevated because some of the circulating 5-HTP is decarboxylated to 5-HT in the kidney and excreted as 5-HT, or 5-HIAA. Patients with foregut NETs are more likely to excrete high levels of 5-HTP in the urine and present with the atypical carcinoid syndrome. However, there is considerable overlap in 5-HTP, 5-HT, and 5-HIAA urinary excretion from patient to patient with carcinoid syndrome. 340 Originally, symptoms of the carcinoid syndrome were attributed to serotonin. 22,233,321 However, the role of serotonin in flushing remains unclear. 233,325 The cause of the flushing may differ depending on the tumor type. In patients with gastric NETs, the red, patchy, pruritic flush is thought to be caused by histamine, because this type of flushing can be prevented by H1 and H2 antihistamines. 233,259,340 Other candidates for mediators of flushing include tachykinins, substance P, neurokinins, and other GI peptides. 12,325,341,343,492 Part 4 Topics involving multiple organs. The pathogenesis of diarrhea in patients with carcinoid syndrome is also complex. Patients with the carcinoid syndrome have increased 5H-mediated colonic motility with a shortened intestinal transit time and, possibly, an alteration in intestinal secretion/absorption. 343,344 Serotonin overproduction is probably responsible for diarrhea in most patients. 16,233,325,343,344 Serotonin, in combination with histamine, may be responsible for producing bronchospasm. With respect to the pathogenesis of carcinoid heart disease, 317,331,345 patients with heart disease have higher urinary 5-HIAA excretion and have higher plasma levels of tachykinins and other peptides than those without heart disease. 12,316,318,328,346,347 Serotonin may be the most important pathogenic factor. 323,331,345,348 Carcinoid-like valvular plaques/fibrosis occur in animals receiving serotonin long-term, as well as in animals deficient in the serotonin transporter gene. 331. Furthermore, serotonin stimulates subendocardial cells in culture and collagen synthesis by heart valve interstitial cells. 317,331 The valvular heart disease caused by appetite suppressant drugs such as the serotonin agonist drug dexfenfluramine is indistinguishable from carcinoid heart disease. Serotonin may also be involved in other fibrotic reactions sometimes seen in the carcinoid syndrome, such as retroperitoneal fibrosis. 233,320,327 Clinical features and diagnosis. The carcinoid syndrome is predominantly associated with midgut, SI, NETs. The most frequent symptoms are spontaneous cutaneous flushing, see Fig 34.8, and diarrhea, followed by bronchospasm with wheezing and asthmatic symptoms and, later in the course of the disease, carcinoid heart disease with primarily right-sided heart failure, see Table 34.11. The typical carcinoid flush is the sudden appearance of a deep red erythema of the upper part of the body, primarily the face and neck, see Fig 34.8. 349,350 Flushes are often associated with an unpleasant feeling of warmth, occasionally with lacrimation, itching, palpitations, facial or conjunctival edema, and diarrhea. Flushes may be spontaneous or be precipitated by stress, alcohol, certain foods such as cheese or exercise, or be pharmacologically induced by injections of catecholamines, calcium, or pentagastrin. 22,233 Flushes may be brief, lasting 2 to 5 minutes, especially initially, or may be prolonged for hours, especially later. With respiratory tract NETs, the flushes can be frequently prolonged, lasting for hours to days, reddish in color, associated with salivation, lacrimation, diaphoresis, facial swelling, palpitations, deep furrowing of the forehead, diarrhea, and hypotension. The flushing with respiratory tract carcinoids has a greater tendency to cause diffuse body involvement, and after repeated flushing of this type, patients may develop a constant red or cyanotic coloration. The atypical flush associated with gastric NETs is also reddish in color but patchy in distribution over the neck and face. It is frequently provoked by food intake, with erythema associated with blotches and wheals with central clearing, frequently occurring around the neck and on the arms, and the lesions are frequently associated with pruritus. 22,233 Diarrhea usually, 85% of cases, occurs with flushing, but it may occur alone in 15% of cases. 16,321,345 The diarrhea is usually watery, less commonly it is frothy or the pale bulky stool of steatorrhea, with 2 to 30 stools per day. Most patients, 60%, have fecal outputs less than 1L/day. 16 Abdominal pain may be present with the diarrhea or independently. 16 Carcinoid heart disease can be a late manifestation of carcinoid syndrome, Fig 34.9, Also see Table 34.11. Point 316,323,328 Fibrous deposits are diffuse and are found most commonly on the ventricular aspect of the tricuspid valve and the associated chordae, and less commonly on the pulmonary valve cusps. Point 233,317,323,331 Valvular lesions on the left side of the heart occur in 30% of autopsy cases, most frequently occur on the mitral valve, and are less. Table 34.11 Clinical features in patients with the carcinoid syndrome feature at presentation, %, range, during disease course, %, range, flushing 70, 23 to 100, 78, 45 to 96, diarrhea 69, 32 to 93, 78, 58 to 100, carcinoid heart disease 26, 11 to 40, 30, 14 to 41, wheezing/asthma 11, 4 to 14, 12, 3 to 18, pellagra 2, 0 to 7, 1, 0 to 5. Data for features at presentation are from Davis Z., Mortel CG, McElrath DC. The malignant carcinoid syndrome. SURG Gynecol Obstet 1973, 137:63744, Norheim I, Oberg K., Theodorsson Norheim E., ETAL Malignant carcinoid tumors. An analysis of 103 patients with regard to tumor localization, hormone production, and survival. An SURG 1987, 206:11525, Garland J., Buscombe Jr., Bouvier C., ETAL Sandostatin LAR, long-acting octreotide acetate, for malignant carcinoid syndrome, a 3-year experience. Aliment Pharmacolder 2003, 17:43744. Data for features during disease course are from Feldman J.M. Carcinoid tumors and syndrome. Semin Onkel 1987, 14:23746, Soga J., Yakuwa Y., Osaka M. Carcinoid syndrome, a statistical evaluation of 748 reported cases. JEXP Clin Cancer Res 1999, 18:13441, Norheim I, Oberg K., Theodorsson Norheim E., ETAL Malignant carcinoid tumors. An analysis of 103 patients with regard to tumor localization, hormone production, and survival. An SURG 1987, 206:11525, Kvals L.K., Mortel C.G., O'Connell M.J., ETAL Treatment of the malignant carcinoid syndrome. Evaluation of a long-acting somatostatin analog. N. English J. Med 1986, 315:66336, Garland J., Buscombe Jr., Bouvier C., ETAL Sandostatin LAR, long-acting octreotide acetate, for malignant carcinoid syndrome, a 3-year experience. Aliment Pharmacolder 2003, 17:43744, Rusniewski P., Ishshalom S., Wymenga M., ETAL Rapid and sustained relief from the symptoms of carcinoid syndrome, results from an open 6-month study of the 28-day prolonged release formulation of lanreotide. Neuroendocrinology 2004, 80:24451, Kahn M.S., L. Coley F., Davies P., ETAL long-term results of treatment of malignant carcinoid syndrome with prolonged release lanreotide, somatuline autogel. Aliment Pharmacolder 2011, 34:23542, Mortel C.G., Rubin J., Kvals L.K. Therapy of metastatic carcinoid tumor and the malignant carcinoid syndrome with recombinant leukocyte A interferon. J. Clin Onkel 1989, 7:8658. Fig 34.9 Carcinoid heart disease. Note fibrotic thickening of the cusps of the pulmonary valve and the endocardium in a patient with small intestinal carcinoid tumor and liver metastases. Chapter 34 Neuroendocrine tumors 493-34 extensive than in the right heart. 233 Tricuspid regurgitation is the most common result, 90% to 100%, followed by tricuspid stenosis, 43% to 59%, pulmonary regurgitation, 50% to 81%, and pulmonary stenosis, 25% to 59%, 318,323,333 at diagnosis. 27% to 43% of patients with carcinoid heart disease are functional class I, 30% to 40% are class II, 13% to 31% class III, and 3% to 12% class 4.318,329 carcinoid heart disease appears to be decreasing in frequency and severity. 22,318,331 This decrease has been attributed to widespread use of SSAs, which control the release of serotonin, tachykinins, and other biologically active agents thought to be important in the pathogenesis of carcinoid heart disease. 22,318,331 Wheezing or asthma-like symptoms, pellagra-like skin lesions with hyperkeratosis and hyperpigmentation, arthritis/arthralgias, changes in mental state or confusion, ophthalmic changes during flushing, and cognitive impairment may also occur. 233,332 Furthermore, a variety of non-cardiac problems caused by increased fibrous tissue have been reported in patients with carcinoid syndrome, including retroperitoneal fibrosis, Peyronie disease of the penis, 351 intra-abdominal fibrosis, especially with SI nets, pleural and pulmonary fibrosis, skin fibrosis, and occlusion of the mesenteric arteries or veins. 320,327 A serious complication of the carcinoid syndrome is a carcinoid crisis. 22,325 Carcinoid crises are usually precipitated during procedures such as surgery, anesthesia, chemotherapy, endoscopy, or interventional radiologic procedures, e.g., biopsies, hepatic tumor embolization. 22,324,326,334 Symptoms of crisis include extreme changes in blood pressure, usually hypotension, but sometimes hypertension, confusion, stupor, profound flushing, diarrhea, bronchospasm, hyperthermia, and cardiac arrhythmias. 22,325 Carcinoid syndrome should be suspected in a patient with a carcinoid tumor if any of the typical symptoms are present, see Table 34.11. To confirm the syndrome, serotonin, or one of its breakdown products is generally measured, see Fig 34.7. In one study 352 of patients with carcinoids, urinary 5-HIAA/serotonin levels were elevated in 14%/18% of foregut, 76%/46% of midgut, and 0% of hindgut carcinoids. 352A24HOUR urine 5-HIAA measurement is generally more specific than serum serotonin measurement. There is a very close correlation between a single plasma 5-HIAA determination and the 24HOUR urinary 5-HIAA excretion. 353 Raising the possibility that plasma measurements could replace the more inconvenient urinary collection that is currently the gold standard but that does not always yield reliable results because of incomplete and improper collection. 353 False positive urinary 5-HIAA results may occur if the patient is eating serotonin-rich foods, such as bananas, plantains, pineapple, kiwi fruit, walnuts, hickory nuts, pecans, and avocados. 354-356 Guaifenesin, acetaminophen, salicylates, and levodopa may also affect urinary 5-HIAA levels. 233,355,356 Elevations of urinary 5-HIAA can also occur in intestinal malabsorption and other conditions. 355 In foregut nets that produce an atypical carcinoid syndrome with increased plasma 5-HTP levels, see Fig 34.7, the urinary 5-HIAA may not be markedly increased. If one properly controls dietary and medication intake, the normal range for urinary 5-HIAA excretion is between 2 and 8 mg/day, although using a higher cutoff, 15 mg/day, may reduce false positive results. 355 Many patients with serotonin-secreting nets have urinary 5-HIAA excretions in the 8 to 30 mg/day range. In one study, urinary 5-HIAA determinations had a 73% sensitivity and 100% specificity for the carcinoid syndrome. 342 Diagnostic difficulties are common in patients who flush for reasons other than the carcinoid syndrome, who have the syndrome but do not flush, who have tumors such as foregut carcinoids where 5-HIAA may be normal or minimally elevated, or in rare patients who flush without metastatic disease. 338,357 The differential diagnosis of flushing is extensive and includes menopausal hot flashes, reactions to alcohol and glutamate, adverse effects to medications, e.g., chlorpropamide, calcium channel blockers, nicotinic acid, chronic myelogenous leukemia, and systemic mastocytosis. 357 None of these flushing conditions causes increased urinary 5-HIAA excretion. Treatment SSAs are the first T-line drugs of choice for treatment of carcinoid syndrome. 233,358,359 Use of somatostatin itself is limited by its short half-life, 2.5 to 3 minutes. 233,360 With the development of the synthetic SSAs such as octreotide, subcutaneous treatment can be given every 6 to 12 hours. 233,360,361 Sustained release formulations, octreotide LAR and lanreotide depot injection, allow control of carcinoid symptoms in the majority of patients with once every 4-week administration. 362,363 Octreotide LAR is administered as an intramuscular injection, whereas lanreotide is administered as a deep subcutaneous injection. Both octreotide and lanreotide share a similar mechanism of action, binding avidly to somatostatin receptor subtype 2, and to a lesser extent with subtype 5. 364,365 Individual responses vary, and some patients require higher doses or more frequent dosing over time. 366,368 To prevent a carcinoid crisis, patients with carcinoid syndrome undergoing procedures should receive an additional somatostatin analog. 207,369 A supplementary subcutaneous bolus dose of 250 to 500 μg octreotide should be given within 1 to 2 hours before the procedure. 207 For emergency surgery in therapy-naive patients, current guidelines recommend a 500 to 1000 μg bolus of octreotide or 500 μg subcutaneously 1 to 2 hours before the procedure. 207 Although some use higher doses 334 and others advise a continuous infusion of octreotide. 207 Short-term adverse effects of SSAs are common, mild, and brief. Most frequent are pain at the injection site, nausea, and diarrhea. Long-term side effects are usually mild and uncommonly lead to drug discontinuation. 94,232,233,359,370 These include biliary sludge/stones, steatorrhea, and deterioration in glucose tolerance. 94,233,366 The incidence of biliary disease in patients treated long-term with octreotide is approximately 30%. With most patients developing sludge and 1% to 10% developing symptomatic gallbladder disease. 94,232,233,367 For a patient with severe refractory carcinoid syndrome and liver-dominant disease, hepatic artery embolization, discussed later, is palliative in most cases. 233,371,373 Patients who develop refractory diarrhea while on standard doses of a SSA may benefit from treatment with telatristat ethyl, an oral tryptophan hydroxylase inhibitor. In the Phase 3 TELESTAR trial, 135 patients with refractory diarrhea, defined as greater than or equal to 4 bowel movements a day, were randomized to receive telatristat at 2 doses, 250 mg TID and 500 mg TID, versus placebo, while continuing on a stable dose of SSA. 374 The primary endpoint was reduction in daily bowel movement frequency. After a 1-2-week double-blind duration, mean reductions in daily bowel movements were 0.81 for the 250 mg dose, and 0.69 for the 500 mg dose. Both doses of telatristat reduced levels of urine 5-HIAA by about 50%. As a result of this trial, the 250 mg TID dose of telatristat was approved for management of refractory diarrhea. The drug is relatively well tolerated with mild nausea and asymptomatic increases in serum GGPT observed in some patients. Constipation is a rare side effect. In patients with symptomatic carcinoid heart disease, valve replacement surgery is typically indicated. 317, 329, 331, 345, 375 with the improved ability to control the carcinoid syndrome preoperatively and perioperatively. Cardiac valve surgery associated mortality has decreased to 10%, and the median survival after surgery can be as long as 11 years. 317, 375 The major indication for valve surgery is right heart failure. 345 Cardiac surgery is associated with a mortality reduction. 329, 345 Tumor localization management of patients with NETs and GINETs requires determination of the tumor extent, stage, and, when possible, the site of the primary tumor. 12, 22, 98, 369, 376, 377 Many tumor localization modalities are available. 12, 22, 98, 369, 377 494 Part 4 Topics involving multiple organs. Endoscopy. As discussed earlier, endoscopy is essential for detection of primary gastroduodenal and colorectal NETs, as well as NETs originating in the terminal ileum adjacent to the ileocecal valve. 378 Occult primary SI NETs can sometimes be detected by capsule endoscopy or double balloon enteroscopy, although routine use of these modalities is not routinely necessary or recommended. Typically, presence of a typical mesenteric mass on cross-sectional imaging is indicative of a primary SI tumor. Endoscopic ultrasonography EUS facilitates T-staging, and possibly end-staging, of gastric and rectal NETs. 12, 247, 250, 260, 299, 379, 381 EUS is also quite sensitive in detecting NETs. 98, 178, 382 and at providing histological confirmation of disease via FNA. EUS detects approximately 80% of insulinomas, range 57% to 92%, which is superior to conventional imaging studies. 12, 71 EUS also detects approximately 70% of gastrinomas, range 40% to 100%. 12, 379 in MEN1 patients, EUS can detect NETs not seen by other modalities and may prove particularly useful for serial assessments of the size of small lesions that are not resected when diagnosed. 12, 381 Computed tomography and magnetic resonance imaging. Abdominal CT and MRI are widely used to assess primary NET location and tumor staging. 22, 376, 377, 382, 385 Many SI NETs are too small to be seen on CT or MRI. Insulinomas and duodenal gastrinomas are also usually small, 1 cm, whereas most non-insulinoma NETs present late in their course and are large, greater than 4 cm, and more easily imaged. 12, 101 To enhance conspicuity of liver metastases, 3-PHASE-CT imaging is recommended using arterial phase, roughly 20 seconds from contrast administration, as well as venous phase, roughly 70 seconds, and non-contrast imaging. Multiphasic imaging can also improve sensitivity of CT scans to detect small pancreatic NETs. MRI is even more sensitive than CT scans for detection of liver metastases. For patients undergoing gadolinium-based MRI scans, gadoxetate disodium, Eovest, contrast with hepatobiliary phase imaging improves conspicuity of small liver metastases. 386 Somatostatin receptor imaging. Somatostatin receptor imaging is useful both for optimal whole body staging of disease as well as assessment of somatostatin receptor expression. The latter function is important for assessing potential benefit of treatment with SSAs and radiolabeled SSAs, discussed later. In the past, somatostatin receptor scintigraphy, SRS, using 1,11-indium pentetriotide, octreoscan, was the primary method of somatostatin receptor imaging. More recently, PET-based 68-gallium imaging using itatriotide, dotatoke, dotanoke, or dotatate, the latter commercially approved, with CT fusion provides greater sensitivity and higher spatial resolution. 387 For somatostatin receptor expressing tumors. 68Ga dotatate PET offers improved sensitivity for detection of metastases as well as small primary tumors compared to either CT or MRI scan. Studies have shown that an appropriately ordered 68 GAD-auditate scan can influence clinical decision-making in a substantial proportion of cases. 388 Although not routinely indicated for surveillance of disease, somatostatin receptor imaging should be performed at baseline in most patients with well-differentiated tumors, as well as prior to consideration of treatment with radiolabeled SSAs, and prior to procedures such as surgery or liver embolization where optimal localization of tumors can be beneficial. Other scanning methods for tumor localization in selected patients with GINETs have been described recently but are not widely available. Insulinomas overexpress receptors for GLP-1, and 1-STUDY389 demonstrated that a radiolabeled GLP-1 analog can detect occult insulinomas not localized by other imaging modalities. 11C and 18-flabieled levodopa has been used to visualize NETs using PET 22,377. 11C5-HTP has also been used. 22,382 PET using 18-deoxyglucose, FDG, may also be helpful in the subset of NETs with high proliferative rates and poor cell differentiation, discussed later. 397,390,391 Treatment of metastatic disease because of the effectiveness of medical therapy, e.g., long-acting SSAs, for patients with carcinoid syndrome and functional NETs. Survival of these patients is increasingly being determined by the tumor's biology and growth pattern. 2,27,92,4,110,207,221,5,227,264,361,364,394,392,502 NETs can grow at different rates in different patients, and rate of growth is a prognostic factor. In general, metastatic NETs are relatively slow-growing compared with more common adenocarcinomas, although poorly differentiated neuroendocrine carcinomas are highly aggressive. 24,126,443,503 Basic categories of treatment include cytoreductive hepatic surgery, liver-directed embolization therapies, and systemic treatments. Cytoreductive surgery: removal of resectable metastatic tumor. Cytoreductive surgery, debulking, and metastasectomy, is often considered, although there are no controlled studies to establish its value. 12,67,94,98,146,204,265,369,394,411,504 Hepatic cytoreductive surgery may be recommended if it is thought that more than 90% of liver metastases can be resected, with 5-YEAR survival rates of 75% to 80% and occasional cures. 12,67,94,146,204,369,394,411,467,504 but such a resection is possible in only 5% to 15% of patients. Hepatic cytoreductive surgery may also be required in patients with functional NETs when other therapies cannot reduce plasma hormone levels sufficiently to control symptoms. 12 Mesenteric adenopathy and/or fibrosis may develop in the mesenteric root in some patients with SI NETs, with resultant intestinal obstruction, abdominal pain, and other symptoms. 282,433,498 Some recommend that mesenteric disease should be debulked in such patients, even if they have liver metastases. 94,265,433,468,498,502 An approach that can relieve or prevent symptoms and may prolong survival. 94,265,433,468,498,502 At the time of cytoreductive surgery, prophylactic cholecystectomy is sometimes performed because of the risk of biliary sludge or stones from future long-term treatment with SSAs. 265,433,478 Liver-directed non-surgical therapies. Several liver-directed therapies target hepatic metastases from NETs. Although they are widely used and mentioned in management guidelines, there are no completed randomized trials comparing them. 282,369,402,502 These liver-directed, non-operative approaches are primarily considered in patients with unresectable NETs with metastases that are limited to the liver or liver-dominant, particularly in patients with functional syndromes in whom the hormone excess state cannot be well controlled by other modalities. 369,372,502 radiofrequency ablation, RFA, and other ablative methods. Locally ablative techniques, RFA, ethanol injection, and cryotherapy of hepatic metastases from NETs can be performed at the time of surgery or percutaneously using interventional radiologic techniques. 94,203, 371, 438, 458, 480, 482, 497 RFA is the most widely used, increasingly in combination with other techniques such as cytoreductive surgery. 203, 371, 438, 458, 480, 482, 497 Relative contraindications to RFA include large lesions, greater than 3.5 cm, numerous lesions. Chapter 34. Neuroendocrine tumors 495. 34, greater than 5, and metastases adjacent to vital structures. 51, 369, 371, 438, 458, 480, 482 Response rates are 80% to 95%, with some responses lasting as long as 3 years. 203, 371, 438, 497 RFA has a lower complication rate, 15%. Compared to cytoreductive surgery or hepatic embolization, discussed next, and RFA results in shorter hospital stays. Serious complications of RFA include bleeding or abscess formation. 203, 371, 497 Although the value of RFA has not been established in a controlled trial, some guidelines endorse RFA as an effective therapy. 94, 146, 369 Hepatic artery embolization and chemoembolization. Most NETs are highly vascular, and interrupting their arterial supply can selectively damage the tumor. The uninvolved liver is less susceptible because it receives the majority of its blood from the portal vein. See Chapter 71. 94, 371, 435 Options include transarterial embolization, TE, alone or combined with intra-arterial chemotherapeutic agents, TACE. The most common chemotherapy drugs used with TACE are doxorubicin, 5-fluorouracil, 5-FU, cisplatin, mitomycin C, or streptozotocin. 94, 371, 435, 440 Embolic particles include microembospheres, polyvinyl alcohol particles, or gel foam powder. 396, 425, 451 Complete or relative contraindications to TE or TACE include portal venous occlusion, significant liver dysfunction, involvement of greater than 50% to 75% of the liver with tumor, surgical biliary reconstruction, and poor performance. Status. 94, 203, 371, 396, 399, 435 From 60% to 100% of patients treated with TE or TACE have symptomatic improvement, and 25% to 86% have an objective tumor response for a highly variable period of time. 371, 399, 435, 451 In patients with the carcinoid syndrome, TE or TACE reduces symptoms in 64% to 75%, and 5-HIAA excretion/tumor markers in 50% to 70%. 486, 5055 5-year survival rates post-embolizations are 30% to 50% in patients with a metastatic GNET and 20% to 35% in patients with a metastatic PNET. 94, 371, 440 Both TE and TACE can lead to death, 6%, and to morbid complications, 10% to 80%, including a post-embolization syndrome of abdominal pain, fever, and nausea/vomiting. 203, 371, 396, 399, 442, 451 Serious complications are uncommon and include gallbladder necrosis, hepatic failure, liver abscess, and renal failure. 94, 203, 371, 396, 399, 442, 451 Recent guidelines concluded that in centers with experience with the procedure, TE or TACE should be considered for palliative treatment in patients with liver-dominant, metastatic nets that are unresectable 146,369. There are no completed prospective randomized studies comparing TAE with TACE. 356 Hepatic radioembolization. Another embolic option for patients with unresectable liver-dominant nets is radioembolization using 90 yttrium, 90Y, microspheres, referred to as selective internal radiation therapy, SIRT. Two types of 90Y microspheres can be used: resin, SIR spheres, Certex Medical, Australia, and glass, Theris spheres, Nordion, Canada. 0.94,395,488. Just prior to intra-arterial administration of 90Y microspheres, a hepatic angiogram is performed to determine that the catheter tip is in the appropriate location and to avoid injection of the microspheres into duodenal or cystic arteries, which could result in duodenal ulceration or cholecystitis, respectively. 0.94,488. Another serious complication to avoid is radiation pneumonitis due to shunting of the 90Y microspheres to the lung. 0.94,488. This latter complication can largely be prevented by confirming that the degree of lung shunting on scintigraphy is 10% or less and by adjusting the 90Y dose. 0.94,444,456,488. A post-embolization syndrome is common following SIRT. 0.356 Grade 2 constitutional side effects, weight loss, fatigue, fever, occur in 43% of patients, and GI side effects are common. Grade 3 short-term adverse effects are rare. However, long-term radiation-induced liver disease represents an important concern, particularly in patients with extensive bilobar metastases. The manifestations of this complication include jaundice, ascites, and a pseudocirrhotic appearance of the liver caused by damage to intrahepatic bile ducts. 0.506 The response rate to SIRT is 55%, range 12% to 89%, stable disease occurs in another 32%, range 10% to 60%, 0.94,395 Symptom improvement, including improved quality of life, is seen in half of patients, with a mean survival of 30 months. 0.94,422,447,455 Liver transplantation. Liver transplantation is used in a small number of patients with metastatic GINETs, although its use is controversial. 0.94,369,421,435,446,465,472,507 In one review, the overall 5-YEAR survival rate after transplantation was 52%, and disease-free survival was 30%. The surgical mortality rate is 10% to 14%. 445,446 in the UNOS database. Overall 1, 3, and 5-YEAR survival rates were 81%, 65%, and 49%, respectively. 472 factors predicting a poor outcome were a major resective surgery concurrent with the liver transplant, poor tumor differentiation, and hepatomegaly. With the recognition of these poor prognostic factors, the overall 5-YEAR survival rate increased to 59% after the year 2000. Reanalysis for additional predictors of poor outcome identified age older than 45, hepatomegaly, and major or minor resective surgery concurrent with liver transplantation. 445 Additional adverse risk factors 94,439,446,465,472 may include a primary net in the duodenum or pancreas. 446 Extrahepatic metastases at the time of transplantation, extensive, 50%, liver involvement, and Ki-67 index above 10%. 94,465 Generally, guidelines restrict liver transplantation to patients with liver-only disease, or to patients with minimal and resectable extrahepatic tumors, i.e., unresected primary sites. Somatostatin analogues SSAs not only control hormone release from functional nets but also have an inhibitory effect on tumor growth. 12,22,94,100,365,401,405,424,508 Despite a negligible objective response rate, the precise mechanism for this anti-proliferative effect is not clear. Except for insulinomas, over 90% of all well-differentiated GEP-NETs possess somatostatin receptors that can activate intracellular cascades that reduce cell proliferation. Somatostatin can also inhibit the release of growth factors from the net or from adjacent cells, and can have anti-growth effects on other cells that may contribute to cancer growth, e.g., vascular, stromal, immune cells. 360,401,5082 pivotal phase 3 trials have established the inhibitory effects of SSAs on tumor growth. PROMID randomized 85 patients with well-differentiated, low-grade metastatic midgut NETs to receive octreotide LAR 30 mg every 4 weeks versus placebo. Median time to progression, the primary endpoint, improved from 6 months on placebo to 14.3 months with octreotide LAR, p.001, 0.365. There was no significant effect on overall survival, possibly because of the small number of patients who died during the study and the ability of patients receiving placebo to cross over to active drug after disease progression. In the Clarinet trial, 204 patients with enteropancreatic NETs, somatostatin receptor positive, Ki-67 index less than or equal to 10%, were randomized to receive lanreotide 120 mg every 4 weeks versus placebo. 364. The large majority of patients, 96%, had stable disease prior to randomization. At the time of data analysis, median progression-free survival, PFS, was 18 months with placebo but had not been reached with lanreotide, HR 0.47, p.001. Side effects of lanreotide included diarrhea, abdominal pain, and cholelithiasis. As a result of the PROMID and Clarinet studies, both octreotide and lanreotide are recommended by various guidelines for management of somatostatin receptor-positive GEP-NETs. Due to similar mechanisms of action and outcomes, there is little data to favor use of one SSA versus the other, nor is there any data supporting use of one SSA after progression on the other. 496 Part 4 Topics involving multiple organs. Interferon alpha. Similar to SSAs, interferon is effective at controlling symptoms of hormone excess states in functional GI-NETs and also has anti-proliferative effects that primarily result in disease stabilization, 30% to 80%, rather than causing a decrease in tumor size, 15%. 0.94,407,43509. The anti-proliferative effect of interferon is thought to be mediated by several mechanisms, inhibiting DNA synthesis, blocking cell cycle progression in G1 phase, stimulating an increase in BCL2, inhibiting protein synthesis, inhibiting angiogenesis via decreased expression of VEGF/VEGFR, and inducing apoptosis. 94,435,01,509. Adverse effects of interferon include flu-like symptoms, anorexia, fatigue, myelosuppression, and hepatotoxicity. As a result of these side effects and lack of well-powered randomized trials confirming benefit, interferon is rarely used for management of GEP-NETs, and considered controversial in guidelines. NCCN Category 3. 369 Everolimus mTOR is a serine threonine kinase that plays an important role in cell growth, proliferation, and apoptosis. 94,477,492,510 Activation of the mTOR cascade plays an important role in the growth of NETs, especially NETs. 94,151,413,464,466,487,490,492,510 The oral mTOR inhibitor everolimus has been studied in 3 pivotal phase 3 trials, all of which evaluated PFS as the primary endpoint. In the RADIANT-3 study, 410 patients with advanced progressive NETs were randomized to receive everolimus, 10 mg/day, or placebo, with crossover allowed upon progression on placebo. Everolimus prolonged median PFS from 4.6 to 11 months, HR 0.35, p.0001, 0.151. The objective response rate was 5%. The most common grade 3 or 4 side effects were myelosuppression, diarrhea, stomatitis, or hyperglycemia, ranging in incidence from 3% to 7%. These side effects were generally manageable by dose reduction or drug interruption. Pneumonitis and infections were among other clinically important adverse effects. There was a non-significant trend toward improved overall survival, OS. The RADIANT-2 study randomized patients with progressive, unresectable, well-differentiated non-pancreatic NETs and history of carcinoid syndrome, primarily midgut NETs, to receive octreotide LAR, 30 mg/month, with either everolimus, 10 mg/day, or placebo. The results of this study were equivocal. The median PFS for the everolimus/LAR patients was 16.4 months compared to 11.3 months in the LAR/placebo group, HR 0.77, P equals 0.026, a difference that did not reach the pre-specified level of significance. OS analysis numerically favored the placebo group, although the results were not statistically significant. The RADIANT-2 study did not lead to approval of everolimus in this population of patients. 511 The last Phase 3 study, RADIANT-4, evaluated everolimus versus placebo in 302 patients with non-functional GI and lung NETs. As a result of the eligibility criteria, a diverse population of lung, gastroduodenal, and colorectal NETs were enrolled, with relatively few midgut NETs compared to RADIANT-2. No crossover was permitted on this study. This study met its primary endpoint, demonstrating improvement in median PFS from 3.9 months on placebo to 11.0 months with everolimus, HR 0.48, p.001. Because of the RADIANT-4 study, everolimus was approved for treatment of non-functional GI and lung NETs. 512 It is unclear whether tumor functional status, history of carcinoid syndrome, should be a determining factor in selection of everolimus for progressive GEP-NETs. In general, everolimus is appropriate for patients with clinically significant progression, and is likely more appropriate in non-midgut versus midgut NETs. Risks versus benefits need to be carefully weighed, particularly in patients who are older, frail, or have clinically significant comorbidities such as lung disease or diabetes. Sunitinib GEP-NETs are highly vascular tumors, expressing both VEGF and its receptor, VEGFR. Several anti-angiogenic drugs have shown activity in single-arm and small randomized studies, but only sunitinib is approved for use in patients with advanced NETs. 369,494,513 Sunitinib is an orally active, small molecule inhibitor of a number of tyrosine kinase receptors including PDGFRs, VEGFR1, VEGFR2, CKIT, and FLT. 3.479,513 in a placebo-controlled trial. 513 patients with progressive, unresectable, metastatic, well-differentiated NETs were randomly assigned to receive either oral sunitinib, 37.5 mg/day, or placebo. Sunitinib increased median PFS from 4.5 to 11.4 months, HR 0.42, p equals 0.001, and was associated with a trend toward OS benefit, outcomes that were very similar to those associated with everolimus in the RADIANT-3 trial. 513 Key adverse events included hypertension, myelosuppression, and palmar-plantar erythrodysesthesia, hand-foot syndrome. 513 Adverse effects were generally manageable with a dose reduction or drug discontinuation. 513 As with everolimus, it is not clear when sunitinib should be used relative to other therapies for patients with advanced progressive NETs. 94,356 Peptide receptor radionuclide radiotherapy 177 Lutetium dotatate somatostatin receptors are highly expressed in most well-differentiated GEP-NETs, and treatment with radiolabeled SSAs allows targeted cytotoxic radiolabeled somatostatin receptor ligands to bind to the tumor. 397, 398, 449, 495 This form of treatment is also known as peptide receptor radiotherapy, PRRT. Several radioisotopes coupled to SSAs have been evaluated including 90 yttrium, 90Y, and 177 lutetium, 177 Lu. 397, 398, 449, 495 The most frequent SSAs used are octreotide or octreotate, an SSA with higher affinity to somatostatin receptor subtype 2, Common chelators are DTPA or DOTA 0.94, 397, 398, 49590Y is a beta-emitting isotope with a relatively long tissue penetration range of approximately 12 mm. In one study of 87 patients, objective radiographic responses observed with 90-DOTA were 28%. Another study, evaluating only patients with refractory carcinoid syndrome, demonstrated an objective response rate of only 4%, but a high rate of stable disease, 70%, 0.514, 1 of the main toxicities involving 90-based PRRT is renal insufficiency, a side effect that can be partially ameliorated with use of concurrent amino acid infusions, which inhibit glomerular reabsorption of the radioactive peptides. 516 in one large series of 1,109 patients treated with 90-based PRRT, 102, 9%, experienced severe renal toxicity. Long-term myelotoxicity, myelodysplastic syndrome or acute leukemia, occurs in roughly 2% of patients. 517-177 Low-based PRRT represents a new generation radiolabeled SSA with a shorter particle range of roughly 2 mm. Studies using 177-ludotatate have demonstrated objective response rates ranging from 18% to 44% with median PFS durations of approximately 30 months. With use of prophylactic amino acid infusions, rates of grade 3 or 4 nephrotoxicity have been 1%. Long-term rates of myelodysplastic syndrome/acute leukemia are approximately 2%. 518-519 The NETTER-1 study, the first prospective phase 3 study of a radiolabeled somatostatin analog, 231 patients with well-differentiated midgut nets and evidence of progression on standard dose octreotide LAR and evidence of somatostatin receptor expression on octreoskin were randomized to receive 4 cycles of 177-ludotatate, 200 mCi every 8 weeks, along with octreotide 30 mg versus high-dose octreotide, 60 mg, every 4 weeks. The primary endpoint was PFS by blinded central radiology review. The study demonstrated a clinically and statistically significant improvement in PFS, with a median PFS of 8.4 months on the high-dose octreotide arm of the study and median PFS Chapter 34 Neuroendocrine Tumors 497-34 not reached with 177-ludotatate, HR 0.21, p.001. The objective response rate with 177-ludotatate was 18% compared to 3% with high-dose octreotide. There was also preliminary evidence of improved OS with 177-ludotatate, HR 0.4, p equals 0.004, which needs to be confirmed on planned final OS analysis. 520 Based on results of the NETTER-1 study as well as a single-arm institutional registry data, 177-ludotatate was approved for treatment of advanced, progressive GEP-NETs. Appropriate selection of patients requires confirmation of somatostatin receptor expression on imaging studies, octreoscan or 68-Ga-dotatate PET. There is evidence that degree of somatostatin receptor expression correlates with tumor response. 521 A standard treatment course consists of 4 cycles of 177-ludotatate, although there is some controversy regarding the potential role of dosimetry in refining treatment dose and number of cycles. For patients who experience a prolonged duration of stable disease or response after an initial course of PRRT, subsequent retreatment is an option. 522 A total of 8 individual treatment cycles, 1,600 mCi, is considered to be a lifetime maximum in some institutions, although some patients may be able to tolerate higher lifetime doses. There is no clear correlation between total treatment dose and risk of irreversible myelotoxicity. Cytotoxic chemotherapy. The role of cytotoxic chemotherapy in GEP-NETs is evolving. It is now evident that NETs are substantially more sensitive to alkylating agent-based chemotherapy compared to midgut NETs. The role of chemotherapy in gastroduodenal and colorectal NETs is not well defined. 481 Streptozicin-based regimens were tested extensively in NETs in the 1970s and 1980s, and found to be active in NETs. 2 key randomized studies were performed. One reported objective response rates of 63% with streptozicin plus 5-fluorouracil, 5-FU, versus 36% with streptozicin monotherapy. 523 Another study reported response rates of 69% with streptozicin plus doxorubicin versus 45% with streptozicin and 5-FU. 524 Neither study used strict radiographic response criteria, making the data difficult to apply in the context of modern treatment outcomes. A more recent retrospective analysis of a triple drug regimen consisting of streptozicin, doxorubicin, and 5-FU demonstrated a response rate of 39% using objective radiographic parameters. 454 Temozolomide is an oral alkylating agent with a more tolerable side effect profile compared to streptozicin. Several small phase 2 studies have evaluated temozolomide in combination with other agents. 400, 483, 525529 A small study of temozolomide and thalidomide reported an objective response rate of 45% in 11 patients with NETs, versus no responses in GI NETs. 529 Another study of temozolomide and bevacizumab reported a response rate of 33% and a median PFS of 14.3 months. 526 The combination of capecitabine, an oral fluoropyrimidine, and temozolomide has been investigated in multiple retrospective series and in a recent prospective randomized clinical trial. In one institutional series of 30 chemotherapy-naive patients with NETs, a radiographic response rate of 70% and a median PFS of 18 months were observed. 400 Another institutional series consisting predominantly of NETs reported a response rate of 61%. 530 Based on these data, a randomized phase 2 study was launched to compare capecitabine and temozolomide versus temozolomide monotherapy with patients with progressive well-differentiated NETs. Their results demonstrated a statistically significant improvement in both PFS and OS associated with the capecitabine/temozolomide combination. Median PFS was 22.7 months with the combination regimen versus 14.4 months with temozolomide monotherapy. HR 0.58, p equals 0.02. Median OS was not reached in the combination arm versus 38 months with temozolomide. HR 0.41. P equals 0.01. The regimen was well tolerated with a 13% rate of grade 3/4 neutropenia and a 8% rate of grade 3/4 thrombocytopenia. 531 Rates of severe nausea are quite low when prophylactic ondansetron is used prior to temozolomide. Capecitabine/temozolomide is currently guideline recommended for management of metastatic NETs. There are conflicting data regarding the potential predictive value of methyl-GUA9 methyltransferase management expression. 532 Thus far, there are no completed studies comparing cytotoxic regimens to non-cytotoxic drugs, everolimus or sunitinib, in the management of progressive NETs. Treatment of poorly differentiated tumors. Poorly differentiated carcinomas comprise fewer than 5% of GEP-NETs. 94, 261, 263, 264, 404, 409 Their recognition is important because of their aggressive course and their distinct treatment from well-differentiated tumors discussed earlier. 263, 264, 404, 499 Poorly differentiated GI-NETs are characterized by their histologic features of aggressive growth, grade 3, with Ki-67 index 20%, and usually 50% to 90%, necrosis, nuclear atypia, rapid growth, and poor clinical prognosis. 94, 261, 263, 264, 404, 499 Histologically, they can be classified as small cell or large cell. These cancers generally contain few somatostatin receptors, therefore unlabeled or radiolabeled SSAs are rarely indicated. 18-FDG PET, CT, and MRI are frequently used to image these poorly differentiated NETs. 264 Because most patients with poorly differentiated NETs present with regional or distant metastases, surgery is rarely curative, although it still should be considered in the occasional patient with limited disease. 94, 263, 264, 404, 499 In the typical patient with inoperable disease, chemotherapy with cisplatin, or carboplatin, plus etoposide, is recommended. These agents induce remission in 14% to 80% of patients. with a mean duration of response of less than 12 Monday THS. 263, 264, 369, 404, 462, 463, 481, 499. The median survival with treatment is 4 to 16 months, and the average 5-YEAR survival is only 11%, range 0% to 31%. 404. The chemotherapy regimens can be associated with significant toxicity, especially GI, nausea/vomiting, myelosuppression, and renal damage. 264, 369, 404, 462, 463, 481. Despite absence of prospective data, patients with localized undifferentiated tumors undergoing surgical resection should generally receive adjuvant chemotherapy using cisplatin, or carboplatin, plus etoposide. Chemoradiation is another option for patients with local or locoregional poorly differentiated neuroendocrine carcinoma and is the treatment of choice for locoregional small cell carcinoma of the esophagus. 533. For platinum-resistant patients, defined as progression within 3 to 6 months of first-line or adjuvant platinum-based chemotherapy, there are few effective treatment options. Immunotherapy with the PD-1 inhibitor pembrolizumab has shown relatively low response rates compared to outcomes in small cell lung cancer. 534. Studies evaluating combination immunotherapy are ongoing.